सुरुवात से वर्कशॉप है ऑनलाइन का ऑनलाइन का हाँ हाँ स्क्वाड हाँ स्क्वाड करायचंय का
एक मला तर दिसतच नाहीये माझ्या पायाखाली काहीतरी ठेवलं पाहिजे.
असं खाली का नाही
नाही
ते ना
ते दिसत नाहीये मला. ते दिसत नाहीये.
सांगता का
अगं ते किती नाही ते असं होतं ते
असं थोडं
नाही
मॅडम
पायाखाली काही
जीवन संजीवनी दो यार, किसी की जिंदगी तुम्हें बचानी है, हमी है दिल की धड़कने जगानी है, तो मत करो फिजूल यार इंतजार, जीवन संजीवनी दो यार। शख्स हो कोई किसी भी राह में, आग में या आग में तालाब में, उस जगह से उसको दूर लेना है, क्योंकि खुद को पहले महफूज रखना है। उसे जगह उसे बुलाओ एक बार, कि सांस बंद है क्या देखो मेरे यार, मदद के वास्ते पुकारो जोरदार, 108 डायल करो यार। मिलाओ दोनों हाथों की ये उंगलियां, बीच सीने के रखो हथेलियां, मिलाओ दोनों हाथों की ये उंगलियां, बीच सीने के रखो हथेलियां, दबाओ सीना जोर से बार बार, कि 1 मिनट में 100 से 120 बार, कि देखो सीना ऊपर आए हर बार, जीवन संजीवनी दो यार। दो इंच सीने को दबाना है, दोनों हाथ तुमको सीधे रखना है, 2 इंच सीने को दबाना है, दोनों हाथ तुमको सीधे रखना है, जो थक जाओ तो दूजे को बुलाना है, कि सर को पीछे जौ को आगे रखना है, रखना खुद पे और खुदा पे एतबार, 30 मिनट तक यार, किसी की जिंदगी तुम्हें बचानी है, हमी है दिल की
झालंय का? येतोय आवाज? हा, ओके. हॅलो, येतोय आवाज ना? हा, ओके. लेफ्टनीच करू का राईटने पण चालेल? म्हणजे माझं म्हणणं
अच्छा मैडम Good afternoon, everyone. I welcome all delegates for this hybrid online and offline annual IMA conference on behalf of IMS Satara. Today on the agenda, we have lamp lighting and Dhanvantari Pujan shortly, followed by a workshop on advanced light support from 3 p.m. to 5 p.m., which will be followed by high tea. Then there will be an inauguration function for the workshops. And then we have a SATCON workshop from 6 p.m. to 8 p.m. So I invite everybody on behalf of President, Secretary, and Executive Committee of IMS Satara. We will begin shortly. Thank you. Hello, everyone. Yeah, we are beginning the conference with lamp lighting program and Dhanvantari Pujan program. For that, I invite Dr. Surya Kumar Khandare, President IMS Satara, Dr. Sharad Jagtap, Secretary IMS Satara, Dr. Madhuri Lime Madam, Dr. Asha Barge Madam, and Dr. Vaishali Chavan Madam for the lamp lighting function and the Dhanvantari Pujan. Hello. I request all delegates to come inside the hall. We are beginning our first workshop and on life support. I invite Dr. Madhuri Limaya Madam to come on stage and start the workshop.
इंट्रोडक्शन करते मी. ISA साताराचा लोगो आहे का? Good afternoon all and warm welcome to the SATCON 2023 and the Basic Life Support Workshop by ISA Satara. We are very much thankful to Dr. Khandare and Dr. Jagtap and all the organizers for realizing the importance of basic life support and giving us opportunity to take this hands-on workshop. We are very proud to say that for the last 14 years, we are doing this social activity of anesthesia awareness and the basic life support training program at the various hospitals, schools, colleges, government offices, NCC camps, etc. And every year, we are training almost 3,000 to 5,000 people. Friends, all of us know the CPR, but can we teach CPR to our staff and relatives with proper steps and techniques? Also, nowadays, common people know compression only life support. So we must know anything more than that. That is ventilation, drugs, and defibrillation. That is the purpose of today's workshop. To begin with, Dr. Asha Barge will enlighten us about the few simple nerve blocks that the surgeon themselves can give to their patients for post-operative pain relief. Then Dr. Vaishali and Jyoti will take hands-on COLS by the guidelines of our Indian Resuscitation Council. Then Dr. Mugdha will cover the additional ventilation part and in brief inform about the drugs and the defibrillation. And later on, Dr. Amruta will guide you how to ventilate the patient even if you can't intubate them. And also she will enlighten about the modern airway devices. To add on, we have also included emergency management in special situations like road traffic accident, drowning, and choking. And for our dear surgeon colleagues, Dr. Asha will explain simple nerve blocks. There are two important announcements. We have already distributed some pre and post forms, workshop forms. So do not hesitate to fill it because you yourself are going to judge it. Nobody else will see your form. Please fill pre-workshop column of it, and those who are attending online can write down the answers on the papers. There are two sets of answer, one pre-workshop and another post-workshop. So judge yourself and please let us know how much workshop was useful to you. Now, for further proceeding, I will hand over the mic to our secretary, Dr. Vaishali Chavan.
Good afternoon, all our IMA friends. Without delaying any time, I will like to introduce our team member, Dr. Asha Barge. She is director of Barge Plain Clinic and Mangalmurti Hospital. She has done her pain management courses like PGDMLS. She is a fellow of Indian Academy of Pain Medicine. She is also fellow of AESULAP Academy of Pain, fellowship in ultrasound guided interventions in chronic pain, recently passed national fellowship examination of Indian Academy of Pain Medicine. She has published her articles in Indian Journal of Pain, Journal of Evolution of Medicine, Medical and Dental Sciences, MISA News. She is a faculty and guest speaker in various national as well as international conferences. She is practicing anesthesiologist since 1996, and she started her own Barge Pain Clinic in 2010. So I request Dr. Asha to continue her topic on simple pain blocks for surgeons. Thank you.
Good afternoon, friends. First of all, I thank IMA Satara office bearers for giving me this great opportunity to present my topic. I also like to thank my mother branch, Anesthesia and ISA Satara City branch, President Dr. Madhuri Lima Madam, Secretary Vaishali Chavan, and Dr. Avinash Bhosle, who is Secretary Maharashtra State, for always supporting me and giving me this opportunity. So let us start with my topic. So my today's topic is post-operative pain management. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. In July 2020, the definition of pain was modified by IASP, that is International Association of Study of Pain, and the definition is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage or described in terms of such damage, with 6 keynotes and the etymology of word pain for further valuable context. The acute pain is a subjective sensation in response to objectifiable signals, the psychical adjunct of a protective reflex. Acute pain is easily identifiable, it is self-limiting, and the warning of ongoing tissue damage, it serves as a protective biological function. Minimal psychological symptoms are seen like mild anxiety. It is usually nociceptive in nature, and symptoms of a disease process experienced in and around the injured tissue. If untreated, it may progress to chronic pain. There are some recent trends in post-operative pain management. Pain is considered as a fifth vital sign and pain relief as a basic human right. So why we need to treat the pain? So there are some biological responses to tissue injury, like there is sympathetic stimulation, there is stress response, neuroendocrine responses, metabolic changes, catabolism, organ system dysfunction, hypercoagulability, hyperalgesia and allodynia, immunosuppression, and psychological dysfunction. The goals of postoperative pain management are to provide continuous effective analgesia that is safe from unwanted side effects, and to improve the quality of life for the patient, facilitate rapid recovery and return to the full function, reduce morbidity, early discharge from the hospital. So when we treat post-operative pain or any kind of pain, we have to consider multimodal approach. So what is multimodal approach? When we use two or more drugs which act on different sites with different routes to achieve reduced dosages, improve the pain relief, reduce severity of adverse effects of individual drugs, earlier discharge from the hospital, decrease cost for the patient, and prevent post-operative persistent pain. So these are the few new delivery systems by which we can give our old drugs like transmucosal, transnasal, transdermal, transpulmonary, sublingual, extended release epidural morphine, and liposomal local anesthetics. There are some drugs which have opioid sparing analgesic effect, and the drugs are paracetamol, NSAIDs, ketamine, dexmedetomidine, capsaicin, gabapentinoids, magnesium, and lignocaine. Now we'll skip the pharmacotherapy part of pain management and we'll straightway move to regional anesthesia or analgesia techniques. So epidural techniques, they are no more gold standard, and local anesthetic based infiltrative techniques, they have become the first line component of multimodal analgesia. Perineural techniques, they are effective, but they are underutilized. Local infiltration analgesia, they have become game changer in orthopedic as well as other surgical practice. The local anesthetic infiltrative techniques and perineural techniques, they focus on the role of simple local anesthetic based infiltrative techniques as a primary component of multimodal analgesia. Wound infiltration, preperitoneal or intraperitoneal administration, transversus abdominal spleen block, or you can call it TAB block, local infiltration analgesia as a single administration or with catheters placed. But perineural techniques, they are very effective but underused. So no, these techniques, they don't have any effects on side effects like hypotension, urinary retention, postoperative nausea, vomiting, and pulmonary complications. So regional analgesia, they have become a part of preemptive multimodal analgesic technique, providing safe and effective postoperative pain management with minimal side effects. They can be done preoperatively, intraoperatively, or postoperatively. If given prior to surgery, we need less sedation during the surgery and patient remains conscious and airways is protected throughout the surgery. So these regional anesthesia techniques, they are appropriate for both inpatient and outpatient settings. They have opioid sparing effects, thus there are decreased side effects, which I told you previously, nausea, vomiting, drowsiness, secondary to less opioid use for pain control. So they reduce postoperative pain, therefore there is greater satisfaction of the patient. They decrease the length of stay in the hospital, and there is early ambulation and discharge, and patient can cooperate for early physiotherapy. These are the some common local anesthetic drugs which are used for pain management blocks. We have given different concentrations and different dosage and the maximum dose of each drug. The simple blocks by loss of resistance technique, this can be practiced by everyone, even the surgeons, and this does not need any special expertise. These blocks can be like tab block, transversus abdominal spleen block, rectus sheath block, ilioinguinal iliohypogastric block, fascia iliaca block. And the main key feature of these blocks is you can feel clicks or pops while you introduce the needle. So there is considerable amount of force is required to pierce the blunt needle through the skin, which obliterates the cushion of subcutaneous fat. This leads to filling of pops in deeper or wrong planes. So once you apply the force, you have to again come back till the skin and slowly you introduce your needle. So after entering the skin, always feel bounce on the fascia before you feel the pop. And these blunt needles, you can get blunt epidural needles also, but if you have limited resources, the simple hypodermic needle, 21 gauge hypodermic needle, you can make it blunt. The sharp tip of that needle, you can hit against the ampule or a sterile bowl repeatedly, and you can make it blunt. So to give all these blocks, we have to first understand the anatomy of abdominal wall muscles and the neurovascular planes. So now we'll go to transversus abdominal spleen block. Transversus abdominal spleen block, it covers the T7 to L2 dermatomes, the intercostal nerves T7 to T11, the subcostal nerve T12, and ilioinguinal iliohypogastric, that is L1. They run in transversus abdominal spleen between internal obliques and transversus abdominal muscle. This block can be performed by two methods, like you can go through triangle of Petit or mid-axillary line. Triangle of Petit, it is formed above by the rib cage, below by the iliac crest. Anteriorly, it is bounded by external oblique muscle and posteriorly by latissimus dorsi. And the indications for tab block, they can be, tab block provides sensory block over a wide area of abdominal wall. It can be performed unilateral or bilateral. Any lower abdominal surgery like bowel surgery, appendicectomy, and analgesia for laparoscopic surgery, hysterectomy, lower segment cesarean section, honiography, upper abdominal top block provides more, it is more effective for the upper abdominal surgery, whereas lower tab block, it is more effective for subumbilical surgeries. 4-quadrant tab block is useful for laparotomies using larger incisions, like extending from the zypisternum to pubic area. The ilioinguinal iliohypogastric block, it provides analgesia for the inguinal hernia repair and surgeries following the suprapubic incisions. So the technique of tab block, the aim is to deposit large amount of local anesthetic in tab, that is transversus abdominis spleen, which lies between internal oblique and transversus abdominis muscles. Petit triangle or mid-axillary line midline approach can be used midway between costal margin and the iliac crest. Skin is cleaned, draped. Blunt needle is entered perpendicular to the skin. First pop can be felt when the needle enters the plane between external oblique and internal oblique, whereas second pop can be felt when the needle passes through internal oblique fascia into the transversus abdominal plane. Then this is the end point of the block. Aspirate carefully, then inject 20 to 30 ml of long-acting local anesthetic. Rectus sheath block, it blocks the terminal branches of T9 to T11 intercostal nerves, which run between internal oblique muscle and transversus abdominal muscle to penetrate the posterior wall of rectus abdominis muscle. and end as anterior cutaneous branch supplying the skin of the umbilical area. The indications for rectus sheath block, it provides analgesia after umbilical and incisional hernia repairs, other midline surgical incisions, supplement to tab block for large laparotomy incisions, mostly performed bilaterally, therefore large volumes of local anesthetic is required. The technique of rectus sheath block, technique is same as tab block. Point of insertion is 2 to 3 centimeter lateral to linea alba, midway between zipisternum and the umbilicus. Blunt needle first passes through anterior rectus sheath and then through rectus abdominis muscle till the resistance is felt over the posterior wall of rectus sheath. Bouncing of fascia. Once you feel bouncing of fascia, that is the correct location, and 15 to 20 ml of local anesthetic is injected in 5 ml aliquots. Procedure is repeated on the other side. So this diagram shows different approaches to rectus sheath and tab block. Ilioinguinal iliohypogastric block. This is a relevant anatomy for this block. The ilioinguinal iliohypogastric nerves, they lie between internal oblique muscle and transversus abdominis muscle. The ilioinguinal iliohypogastric block, it is used for inguinal herniorrhaphy and orchidopexy, most common indications. This can also be used for lower incision obstetric and gynecological surgery. Injection is given at 2 centimeter medial and 2 centimeters cephalad to anterior superior iliac spine. Initial pop is felt when you cross the external oblique aponeurosis and 5 to 10 ml of local anesthetic is injected. Then needle is inserted deeper until second pop is felt when internal oblique is penetrated and further 5 to 10 ml local anesthetic is injected to block iliohypogastric nerve. Subcutaneous injection of 3 to 5 ml local anesthetic can also be made at entry point to block remaining sensory supply. So this is a diagram. In this diagram, the right one, we have shown the rectus sheath block, transversus abdominis, and as well as the ilioinguinal block. Now, this is the picture and relevant anatomy related to fascia iliaca compartment block. We have to draw a line at anterior superior iliac spine to pubic tubercle, and this line is considered as a inguinal ligament, and we have to divide this line in 3 parts. So at the junction of medial 2/3 and lateral 1/3, we have to mark, and 1 centimeter below this line, we have to mark a point, and this is the entry point for fascia iliaca compartment block. The indications for fascia iliaca block: perioperative analgesia for thigh, hip joint, and femur surgeries, commonest indication being fracture neck femur. Landmarks are anterior superior iliac spine, inguinal ligament, pubic tubercle. Line is drawn, divided into 3 parts, 1 centimeter below, medial 2/3, lateral 2/3. Point is marked, that is entry point. Patient is supine, blunted needle is introduced, insert perpendicular to the skin. First resistance, then you feel bounce, and then you pierce the fascia lata, that is first pop. Second resistance, feel the bounce, fascia iliaca, that is second pop. Aspirate, if no pain, then inject long-acting local anesthetic. So the conclusion is facial plane blocks form mainstay of multimodal analgesia. LOR techniques, that is loss of resistance techniques, are simple, easy to learn, minimal resources are required, highly cost effective, provide excellent analgesia, and can be used as rescue analgesics. Thank you so much.
माझं नाही आता पहिलं आणि दुसरं. Thank you, Asha, for very good technique review about the operative nerve blocks. I'm sure many surgeons will do it. And now coming to our main part of compression only life support. There is one form, pre-workshop and post-workshop. So for the online people, I will read out the question and answers. They can put answers at home on paper, and then after the workshop, again, there is a answer sheet. So please don't be afraid to put the answers because you are the judge. Nobody else is going to see it. So the first question will be, being a doctor, you know CPR, but can you teach CPR to your staff and relatives with proper steps and techniques? Yes or no? Second question is, diagnosis of cardiac arrest outside the hospital is made by absent peripheral pulse, no heart sounds, loss of consciousness, or no respiration. Note that one or two alternatives may be correct. Cause of cardiac arrest must be known before starting CPR. Yes or no? What equipments are must before starting cardiac compression? Oxygen, drugs, ambu bag, or none? Irreversible brain damage occurs within how many minutes after cardiac arrest? 10, 20, or 30? Does every fainting or collapsing victim require CPR? Yes or no? For cardiac compression, we must be at the of the patient, head end, foot end, or right or left side. What will be our position to give CPR? Standing, sitting, or leaning? Rate of cardiac compression per minute will be 80, 100, or 120. Depth of cardiac compression approximately in centimeters will be either 2 centimeter, 5 centimeter, or 10 centimeter. In two rescuer CPR, how many breaths per minute are supposed to give? 5, 12, or 20 per minute. Cardiac compression to ventilation ratio will be 15 compression to 2 ventilation, 30:2, or 60:2. If the patient has head and neck injury, how should we open airway? By the head tilt, chin lift, or jaw thrust? When inserted in a patient, LMA is usually situated in relation with vocal cords, superior, inferior, posterior, and lateral. And do you know any simple techniques other than analgesic? I think everyone must have heard this lecture just now. Now coming to the proper compression only life support. This hands-on demo will be given by Dr. Vaishali Chavan, our secretary, ISA Satara branch. She has done MBBS and DA from VMMC Solapur. She is practicing in Satara since 1996. She is Associate Fellowship of Rational Emotive Behavior Therapy from Albert Ellis Institute, New York. She has written many articles, given public speeches, TV and radio interviews for mental health awareness, rational emotive behavior psychotherapist at Maitra Clinic, and she is associated with Brain and Mind Gym and Navachetana Care Center. Our second speaker will be Dr. Jyoti Mohite. She is working in Kranti Singh Nana Patil Civil Hospital since 2006. And she is also a private practitioner since 2009. She has done a remarkable work during COVID pandemic. So I request Dr. Vaishali to proceed further.
गुड आफ्टरनून ऑल. सातारा ISS ब्रँच ही गेले 14 वर्ष COLS म्हणजेच कॉम्प्रेशन ओनली लाईफ सपोर्ट ह्याचे प्रोग्राम सातारा आणि आसपासच्या शहरामध्ये घेते. आजच्या आपल्या कॉन्फरन्समध्ये ह्या सगळ्याचं महत्त्व जाणून संयोजकांनी हे पूर्ण वर्कशॉप ISS साताराला डेडिकेट केल्याबद्दल मी संयोजकांचे खूप मनापासून आभार मानते. आणि आपल्या पुढच्या स्लाइड्सना आपण सुरुवात करूया. कॉम्प्रेशन ओनली लाईफ सपोर्ट हा पार्ट मी आणि डॉक्टर ज्योती जाधव असं घेणार आहे. त्यानंतर बाकीचे BLS आणि काही ड्रग्ज आणि डिफिब्रिलेटरचे जे काही पार्ट आहे ते आमचे बाकी कलिग डॉक्टर मुग्धा आणि डॉक्टर अमृता घेतील. तर COLS ह्याबाबत आपण जेव्हा विचार करतो त्यावेळेला असं खूपदा असं लक्षात येतं की इकडे कुठं मॉलमध्ये किंवा कुठं रस्त्यावरती ऍक्सिडेंट होतो किंवा कुणी अचानक हार्ट अटॅक येऊन कोसळतो. तर त्यावेळेला बऱ्याचदा बघ्यांची गर्दी जमते आणि त्याच्यामध्ये बऱ्याचदा कुणी त्याला मदत करायला नसतं किंवा काही वेळेला आपल्या हॉस्पिटलमध्ये सुद्धा अशा प्रकारचे मिसहॅप घडतात. त्यावेळेला दरवेळेला आपण डॉक्टर म्हणून तिथं अवेलेबल असूच असं नाही होत किंवा छोट्या नर्सिंग होममध्ये OPDs मध्ये ह्या पद्धतीचं काही म्हणजे कार्डियाक काही जे काही डिफिब असेल किंवा ड्रग्ज असतील ते असतीलच असं नाही. त्यामुळं कॉम्प्रेशन ओनली लाईफ सपोर्ट हा जो भाग आहे हा खूप महत्वाचा आहे आणि तो डॉक्टरांसकट सगळ्यांनी शिकला पाहिजे आणि पॅरामेडिकल लोकांनी, नर्सिंग स्टाफनी आणि इतरही कॉमन मॅननी हा शिकला पाहिजे. हा आमचा मनापासून गेले 14 वर्ष प्रयत्न चाललाय. तर आपण सुरुवातीला बघूयात की ह्या सगळ्या ज्या काही आता प्रत्येक चित्राचं एक्सप्लेनेशन आपल्याला गरजेचं नाहीये, पण ह्या सगळ्या इलेक्ट्रिक शॉक असेल, ऍक्सिडेंट असेल, आग लागलेली असेल किंवा ड्राउनिंग असेल, ह्या सगळ्यामध्ये आपल्याला लक्षात येतं की काही गोष्टी पेशंटची हृदयक्रिया किंवा श्वसनक्रिया बंद पडलेली असू शकते. रिसेंटली आपण काही केकेचा मृत्यू आपण बघितलाच की कॉन्सर्ट नंतर 2 तासांनी त्याला छातीत दुखायला लागला आणि त्यानंतर कितीतरी वेळ गेला आणि त्या सगळ्यामध्ये त्याचा प्राण गेला. APJ अब्दुल कलामांचं आपल्याला माहितीच आहे, अतिशय शिलाँग मधल्या टॉप इन्स्टिट्यूटमध्ये भाषण देत होते, तिथं ते कोसळले. पण त्यांना COLS देण्याऐवजी त्यांना शिफ्ट करण्याकडे वेळ गेला. माहिती नाही ते COLS देऊन वाचले असते का नाही, परंतु तो एक प्रयत्न करू शकलो असतो आपण, पण तो तिथं झाला नाही. तर त्या दृष्टीनं COLSचं एक महत्व नेहमी आपण अधोरेखित मनामध्ये केलं पाहिजे की हे गरजेचं का आहे. तर कदाचित एखाद्या व्यक्तीचं प्राण आपण COLS देऊन वाचवू शकतो. कारण असं स्टडीमध्ये म्हटलंय की जवळजवळ 70% कार्डियक अरेस्ट हे हॉस्पिटलच्या बाहेर होतात, म्हणजे घरात किंवा आसपास आपल्या आजूबाजूला कुठेतरी होतात. तर दरवेळेला हॉस्पिटलची हेल्प मिळेलच असं नाही किंवा हॉस्पिटलच्या अगदी आसपास जरी झाले तरी सुद्धा हॉस्पिटलमध्ये आणेपर्यंत, शिफ्ट करेपर्यंत, मामा मावशी बोलवेपर्यंत, डॉक्टर बोलवेपर्यंत खूप महत्वाचा वेळ जात असतो आणि त्याच्यामध्ये ब्रेन डेथची शक्यता जास्त असते, हे असं आपण सगळेजणच जाणतो. याचा दुसरा एक भाग असा आहे की CPR दिल्यानंतर व्यक्तीला वाचवण्याची शक्यता एक निर्माण होतेच होते. पण याच्यामध्ये आम्ही असं म्हणतो की आपली स्वतःची सुद्धा एक आमचा स्वार्थ आहे की न जाणो आपल्यालाच कुणाला गरज लागली, दुर्दैवाने तसं होऊ नये, पण चुकून लागली तर आपल्या आसपासच्या लोकांना COLS माहिती असेल तर आपल्यावरती सुद्धा ते COLS ट्राय करू शकतात आणि आपल्याला सुद्धा काही हेल्प मिळण्याची पॉसिबिलिटी वाढू शकते. आता ह्याच्यामध्ये आपण लक्षात घेतलं पाहिजे की ह्या COLSचा जो स्टार्ट आहे तो ॲज अर्ली ॲज पॉसिबल केला पाहिजे. कारण प्रत्येक मिनिट ह्याच्यामध्ये महत्वाचं आहे. ॲज अ मेडिको आपण हे जाणतोच की 4 ते 6 मिनिटानंतर ब्रेन डेथ व्हायला सुरुवात होते आणि 10 मिनिटानंतर पूर्ण ब्रेन डेथ होतो. त्यामुळे प्रत्येक मिनिट जे आपण गमावतो COLS स्टार्ट करायला त्याच्यामधनं 10-10 सेकंद आपण त्या व्यक्तीला मृत्यूच्या जवळ नेत असतो. त्यामुळं प्रत्येक मिनिट महत्वाचं आहे. म्हणजे इथं आपली रेस ही टाइमशी आहे हे आपण लक्षात घेतलं पाहिजे. ह्यामध्ये COLS देताना किंवा देत राहिलं की इतर जे पुढची ॲम्ब्युलन्स येणं असेल किंवा AEDचा उपयोग असेल हे आता आपण पुढे बघूयातच. तर ते देण्यामध्ये सुद्धा आपल्याला असं लक्षात येतं की त्या व्यक्तीला अधिक हेल्प होते. कारण तोपर्यंत त्याचं सर्क्युलेशन कुठे ना कुठेतरी सुरू ठेवण्यामध्ये COLS हेल्प करत असतो. ह्याच्यामध्ये आपल्या जवळच्याच घरांमधल्या लोकांना किंवा मित्रांना, आता अगदी ह्या फेब्रुवारीमध्ये 2 इन्सिडेन्सेस असे माझ्या अगदी जवळच्या लोकांच्या मध्येच घडले की 37 आणि 42 वर्षाची तरुण माणसं ही हार्ट अटॅकने गेली आणि घरात कुणालाही हे माहिती नव्हतं आणि त्यांना नुसतंच गडबडीनं हॉस्पिटलमध्ये नेण्यामध्ये वेळ गेला. तर कदाचित हे अशा पद्धतीचे मृत्यू वाचू शकले असते. त्यामुळे CPR हे ट्रेनिंग सगळ्यांनी घेणं गरजेचं आहे. विशेषतः जसं आता मॅडम म्हणाल्या की आपल्याला माहिती असू शकतं, पण आपल्या स्टाफला आणि आपल्या आसपासच्या पॅरामेडिकल लोकांना आपण हे कितपत इफेक्टिव्हली देऊ शकतो, तर ते आज आपण मुख्यत्वे करून इथं बघणार आहे. त्याचं आपण मॅनिक्विन वरती काही हँड्स ऑन पण देणार आहोत. ओके. COLS चा एकूण पर्पज आहे की कार्डिओपल्मोनरी फंक्शनिंग हे रिस्टोअर करणं, इरिव्हर्सिबल ब्रेन डॅमेज हे प्रिव्हेंट करणं. आता हे डेथ कन्सेप्ट मध्ये आपण की क्लिनिकल डेथ म्हणजे काय की इट हॅज बीन डिफाईन्ड बाय नॉगोव्स्की दॅट द period of respiratory, circulatory and brain arrest during which initiation of resuscitation can lead to recovery within pre-arrest central nervous system function. It is somewhat reversible condition, but biological death, which says after clinical death, it is irreversible because it can lead to cellular destruction. So under normal temperature, from clinical death to biological death, the period does not exist more than 3 to 6 minutes. So we need to apply COLS as early as possible. That नंतर आपण ह्याचे स्टेप्स बघूयाच की we do not waste time in diagnosing cardiac arrest. That is the first thing that Jyoti will tell all about this. One more thing is most survivor of cardiac arrest are from the group of patients whose collapse is witnessed by a bystander, because he also needs to learn COLS and he can apply COLS. Most survivors of cardiac arrest are from group who receive cardiopulmonary resuscitation within 4 to 5 minutes and who received advanced cardiac life support, that is defibrillation, intubation, drug therapy within first 10 minutes. The basic life support, it includes mainly COLS that we are going to see, and then BLS. It is the application of artificial ventilation and circulation without special equipments or drugs to prevent brain damage. Indian Resuscitation Council has modified the algorithm of CPR as ABC to CAB, considering the differences in infrastructure, healthcare facilities, and awareness of general population about CPR. कारण हे अमेरिकेतले क्रायटेरिया आपल्याला इथं लागू करता येतील. आपलं जे इन्फ्रास्ट्रक्चर आहे, आपले जे सोशल कंडिशन्स आहेत, आपले हेल्थकेअर स्ट्रक्चर जसे आहेत, त्या पद्धतीनं आपल्याला आपल्या लोकांच्यासाठी, आपल्या लोकांकरता आणि आपल्या लोकांद्वारे करता येईल अशा पद्धतीचं गाईडलाईन्स इंडियन रिससिटेशन काउन्सिलने आपल्याला दिल्या आहेत आणि त्याच आपण इथं यूज करणार आहे. आपल्याला ह्याच्यासाठी काय लागतं तर एक बेसिक नॉलेज ऑफ CPR, COLS and BLS, willingness to help and your 2 hands only, and if available AED. ते पण कशा पद्धतीने अप्लाय करतात ते इथं आपण बघणार आहोतच. सो अजिबात ह्याच्यामध्ये वेळ घालवणं उपयोगाचं नसतं, कारण आपण बघितलं की 3 ते 6 मिनिटाच्या आतच आपल्याला रादर पहिल्या काही सेकंदातच आपल्याला COLS चे कॉम्प्रेशन सुरू करायला लागतात. So diagnosis of cardiac arrest is not needed in COLS. These first important things we need to take in consideration. So we don't waste time in measuring blood pressure, taking pulse, auscultation of cardiac sounds, etc., etc. So these are some cardiac signs of cardiac arrest: loss of consciousness, absence of pulse on carotid arteries, respiratory arrest, and enlargement of pupils. So loss of consciousness is about 10 to 15 seconds after cardiac arrest. Electroencephalogram becomes flat. Electrocardiogram becomes flat after 30 seconds. Respiratory arrest may be 30 seconds after cardiac arrest. Pupils dilate fully after 60 seconds. Brain damage takes place within 4 to 6 minutes after cardiac arrest, and irreversible cerebral cortical damage occurs within 8 to 10 minutes after cardiac arrest. So no CPR, do CPR. So time is life. So victim chances of survival are reduced by 7 to 10% with every minute that passes without defibrillation and COLS. You can add this COLS also. So what is COLS? So we know when गाडी जेव्हा बंद पडते तेव्हा आपण ढकल स्टार्ट करतो, तसंच हार्ट बंद पडतो त्यावेळेला आपण हार्टला धक्के देऊन ढकल स्टार्ट करत असतो. तर ह्याच्या पुढचं जे प्रोसिजर आहे की हाऊ टू ढकल स्टार्ट अवर हार्ट, The procedure will be explained by our fellow colleague, Dr. Jyoti Jadhav Mohite. So I invite Dr. Jyoti to come to the dais, and I request Dr. Limay Madam to introduce Dr. Jyoti. चालेल. हा.
Good afternoon, respected doctors present over here and all watching online. I am continuing this session of COLS. Thank you, Vaishali Madam. What are the core links in adult COLS? That is early recognition and activation, early chest compressions, and early transfer. These are the situations where we will observe these cardiac arrest patients like road traffic accident, fire, drowning, sudden anaphylaxis to drugs in operation theater, outside the operation theater, sudden cardiac arrest. What is the next? That is the ensure the safe place. If the incidence is occurring in the road, take the patient side of the road at fire station, then take away from the fire. If it is occurring in the electric current area, then take the patient away from the wires. After securing safe place, what will we do? We will check the response. How we will check the response? Tap on shoulder and ask loudly, hello, hello, how are you? Are you all right? If the patient is responsive or it is non-responsive. If the patient is responsive, then observe and shift to the nearest medical facility. If the patient is non-responsive, then what next? Shout for help. You alone could not do anything. Then call for ambulance 108 or local emergency number. Use your mobile to call 108, and what you will say, identify yourself, identify the location, identify the victim's condition, age, sex, what is the condition, and start early chest compressions. 30 chest compressions, 30 chest compression, 5 cycles within 2 minutes. How is the identification of position and placement of hands during this chest compression? Identify the xiphoid process, that is the lowest end of the breastbone. Keep heel of hand 2 fingers above the xiphoid process, lowest end of the breastbone. Keep other heel of the hand over the first one with fingers interlocked. Identify the breastbone. Keep 2 fingers above the xiphoid process. Keep heel of one hand over the xiphoid process. Then keep other hand of the hand over the first one and interlock fingers. Elbow straight, shoulders above the victim's chest, fingers interlocked. Effective chest compressions are push at least 5 centimeters, but not more than 6 centimeters per minute. Allow the complete chest recoil between the compressions without lifting hand from the chest. Do not start chest compressions unnecessarily. What are the effective chest compressions? 30 compressions in 1 cycle. Count 1, 2, 3, 4 up to 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 up to 30. Maintain the speed and number of the chest compressions. If more than 1 person, interchange every 5 cycles. How long to continue the CPR? Till the medical help arrives, another trained rescuer arrives. If the victim is revived, obvious signs of life are there. Rescuer is exhausted or the place becomes unsafe. Responsive victim, if the victim is moving, coughing, vocalizing, place victim in the lateral position, that is the recovery position. At many places, AED is used like airports to save this life. It is different from defibrillator. It is for early defibrillation and can be used by lesser trained personnel as it performs rhythm analysis, gives information by voice or visual display, and it gives the delivery of the shock, and it is given automatically. What are the common side effects of this CPR? Aspiration, vomiting, broken rib bones, internal brain injuries, abdominal distensions, aspiration pneumonia. Do not attempt resuscitation. In which patients? Decapitation, rigor mortis if present, evidence of tissue decomposition, dependent lividity is there. Do not resuscitate, clearly mentioned by the treating physician, like septic shocks, cardiogenic shocks. This is the conclusion. CPR is the responsibility of a team of personnel and not one person in isolation. Train and teach CPR. This is the website to learn CPR more, given by IRC, Indian Research Council. So train more hands, save more lives. चला जीवन संजीवनी क्रिया उगत करूया आणि जीवनदाता बनूया. Thank you.
It is my immense pleasure to introduce you our next speaker, who will deliver one of the most important talks of our conference, Dr. Mugdha Abhishek Mahajan. She is a consultant anesthesiologist currently practicing in Satara city. She completed her MD in Bharati Vidyapeeth, Pune, standing first in her class in 2016. She also completed her DNB in 2018 in first attempt, managing family and personal life. She joined Civil Hospital Satara and continued to work there as a specialist for 4 years. Since past 2 years, she is a freelancing anesthesiologist here in Satara. She is an active member of our ISA and has delivered multiple lectures on CPR to doctors and non-medicals. She has conducted workshops in CPR in few dermatological conferences in the past as well. I request Dr. Mugdha to come on the dais and deliver her lecture. Thank you.
A very good afternoon to all the colleagues. My topic for today's presentation is ventilation, drugs, and defibrillator, and its use in BLS as well as in ACLS. So I'll begin with a few acronyms or abbreviations. So we are all we've heard of all these abbreviations, but very few people are all actually knowing its full form. So CPCR is actually the C for cerebral has been recently added. So it stands for cardiopulmonary cerebral resuscitation, whereas BLS stands for basic life support, and ACLS or ALS stands for advanced life support. So first two, that is CPR and BLS, you can do it in your consulting room if any of your patients who's there waiting in your consulting room suddenly collapses. But the last one, that is ACLS, will be requiring a specialized setup like ICU and a trained personnel. So what does BLS involve? It is basically early recognition of the medical emergencies and activation of the emergency response system, that is CPR. CPR is actually a part of BLS. So whenever there is a collapsed patient, we'll be beginning with CPR. And BLS in turn is a part of broader ALS. And what does ACLS involve? It involves all the interventions such as drugs and defibrillator that are made in response to sudden cardiac arrest, stroke, or airway obstruction. So for our routine practice, we all must be knowing everything of CPCR and at least the basics of BLS to save lives. So what is BLS? As already told by my colleagues, now the sequence has been changed from ABC
to CAB. That is, first we'll begin with chest compressions, giving importance to circulation, followed by airway, and then followed by breathing. So the sequence has been changed in by Indian Resuscitation Council in 2010. So first we'll begin with, there's a collapsed patient in front of us. So what will we do? We'll first check his pulse and breath simultaneously, not taking more than 10 seconds. So how do we do that? This is how we do. We listen, look, and feel for breathing, and simultaneously doing so, we'll be palpating the carotids, and this all should take less than 10 seconds. So we'll arrive at a particular inference. Whether by looking at the breath and chest, we'll come to know whether it's a cardiopulmonary arrest or it's a respiratory arrest. So we have to distinguish between the two entities. So if it's absence of breath sounds or abnormal breathing like gasping and definitive absence of carotid pulse, then it is cardiopulmonary arrest, in which case we have to immediately start with the chest compressions. But if there is absence of breathing with definite carotid pulse, that means the patient is in respiratory arrest. In such case, we have to give rescue breaths of tidal volume every 5 seconds, and each breath will be lasting over 1 second. So it will be approximately 10 to 12 breaths per minute. So in CAB, the compressions has already been covered. So I'll be dealing with airway. So what are the airway interventions that are done during CPR? There will be compression only CPR, that is COLS, with or without airway opening, mouth to mouth ventilation, mouth to mask ventilation, bag mask ventilation with or without oropharyngeal airway, and advanced airways, that is supraglottic airway devices and tracheal intubation using laryngoscopes. So what are the, in order to deliver the breaths, we have to open the airway because the patient is unconscious, his tongue has fallen back, the pharyngeal muscles have lost their tones. So the airway is going to be obstructed. So these three maneuvers will help us open the airway, which are there. These are chin lift, head tilt, and jaw thrust. So by doing all these maneuvers, that jaw thrust, we are going to push the mandible at the temporomandibular joint forwards, lift it, and tilt the head. All these are going to pull the tongue forwards and open the airway in order for us to deliver the rescue breaths. But remember that no head tilt should be given in suspected cervical vertebral fracture patients. So this is followed by breathing. Breaths. So rescue breaths, once the chest compressions have begun, we'll be giving rescue breaths of tidal volume over 1 second, and we have to allow 1 second for exhalation. And 2 breaths are to be given after 30 chest compressions. So 1 cycle of CPR consists of 30 chest compressions followed by 2 breaths. Breaths can be delivered via face mask or mouth-to-mouth respiration. This is mouth-to-mouth respiration. So we don't do this nowadays, but just for the sake of completion, how you're going to do it, you will be doing head tilt, jaw support, and you will be pinching the nose in order to trap the air or not allow the air to escape, and form a mouth seal and give a respiration. This is mouth to mask ventilation. Now the previous one had a disadvantage of getting exposed to the patient's breath. So basically in mouth to mask ventilation, what you do, you will be using a mask that will be kept over the patient's airway, forming a tight seal using a C&E technique, which I'll be telling you in the upcoming slide. Then attach an angle connector, and oxygen source is also attached, as you can see, to the mask. And then you will be delivering a rescue breath. So this basically has an advantage of not getting exposed directly to the patient. This also can be done using supraglottic airway devices like this. You can put the LMA and attach a HME filter to which you will be delivering a rescue breath. So this is mouth to mask ventilation. Next comes our gold standard bag and mask ventilation. Everyone must have seen this. This is basically done by using an ambu bag and a face mask. The face mask has a C&E grip. So as you can see in the picture, your thumb and index finger, they form a C. around the mask opening, whereas the middle ring and the little fingers will be forming E, and they will be kept over the mandible of the patient. And by using both your hands, you are going to form a tight seal around the airway and give rescue breaths. Next comes advanced airway techniques. This will be discussed in details by Dr. Amruta, but I'll just be giving you a brief. We've already seen endotracheal intubation and direct laryngoscopy. This forms the mainstay of advanced airways, but other techniques or recent advances include video laryngoscope and a variety of supraglottic airway devices such as LMA Classic, Ambu LMA, LMA ProSeal, iGel. So after like establishing the airway, like by using endotracheal intubation or SGA, and we are like we have started the chest compressions, giving 2 rescue breaths. So how we are going to proceed with our CPR? So victim will be assessed after every 5 cycles of chest compression. Each cycle consists of 30 chest compression and 2 breaths, and it will take approximately up to 2 minutes. So what are the possible situations that you will face in the assessment? We'll first check the pulse and check for the breath. If breath is absent, then and the pulse is present, that means the circulation is established, but breathing has not yet started. So you will be giving rescue breaths every 5 seconds and reassess the victim every 2 minutes till the victim is shifted by the ACLS team. If a pulse is present as well as breath is present, it means you have successfully resuscitated the patients and his spontaneous cardiac and respiratory activity has come back to normal. So, but if the pulse is absent and there is no breaths, that means you have to again proceed further with your CPR and continue with another 5 sets of CPR. That will include 30 chest compressions and 2 breaths, and reassess the carotid pulse thereafter. Now, early defibrillator. Defibrillator is a part of BLS, and it is done in selected cardiac conditions, but you have to be adept to its use. So you should also have it and you should know how to use it. So defibrillator is basically what does it do? It provides an electric shock to the heart in order to revert it back to the sinus rhythm from potentially fatal arrhythmias that include ventricular tachycardia and ventricular fibrillation. So we can defibrillate only in 2 of these arrhythmias. So the shockable, or they are called as shockable rhythms. The shockable rhythms are ventricular fibrillation and ventricular tachycardia, whereas the non-shockable rhythms include asystole and pulseless electrical activity. So how we are going to deliver the shock? Will be there's a pulseless patient. We have started with the CPR and we have called for help. We have sent someone to get the defibrillator or AED and waiting for it to arrive. So once the defibrillator is there, we'll be attaching the pads on the patient and reading the rhythm. If it's going to be AED, it will itself diagnose VTAC or ventricular fibrillation and tell us to deliver a shock. So once the rhythm is detected and it's shockable, you will be charging the defibrillator. Before delivering the shock, you have to make sure that nobody is touching the patient directly or to the bed. So you have to shout all clear and then deliver the shock. How we are supposed to put the defibrillator paddles on the patient's chest? One is below the right shoulder and the other one is below the second intercostal space around the nipple area. So this is a sternal pad and a lateral pad. So in the picture, you can see a compact automated external defibrillator, and any lay person, even a person who's a bystander, like you are in a mall and the patient has collapsed, that person also will be able to deliver the shock. So there are all instructions written. There are 2 pads. You have to stick it, one below the right clavicle and the other on the lateral aspect left beneath the left nipple. It will detect whether the rhythm is shockable or not, and then you will be delivering. If it is shockable, you will deliver the shock. So if AED is being used, it can review the patient's rhythm to decide if it needs a shock. AED charges itself and provides verbal instructions on how to use it. So this is a picture depicting a conventional defibrillator, which you can see even on the dais, and an automated external defibrillator. So this is just a pictorial presentation of how we are going to give the shock and proceed with the CPR. There will be first begin with the CPR, and there should be minimal or very less interruption between the chest compressions and attaching the pads and delivering the shock. So you will attach the pads if the rhythm is shockable. We will be charging the defibrillator, shout all clear, deliver the shock, and immediately you have delivered the shock. You will not wait whether the ventricular fibrillation or VTAC has reverted back to sinus rhythm or not. You will directly continue with the CPR without wasting any time. And after 2 minutes, you will be assessing the patient and see whether the rhythm has been restored or not. Now, what is the energy used in CPR? Energy of defibrillator. So first, one initial shock that is advised as soon as the shockable rhythm is detected. And for biphasic defibrillator, will be using 150 to 200 joules. And in case of children, it will be 2 joules per kgs for initial shock. And for monophasic, it will be 360 joules. And the post shock rhythm is not, as I told, not checked immediately. It will be checked after 2 minutes of chest compressions, and subsequent strength of the shock should be either equal or higher than the previous shocks. Now next is drugs. Drugs basically are a part of our BLS as well as ACLS protocol. After securing a large bore IV line at the outset, you can give multiple drugs. But it is essential that you should keep all the emergency medicines or drugs handy, and they should be regularly checked for expiry, because we are not going to use them often, but we need to have them handy. What are the important drugs? First is adrenaline. Adrenaline ampule has 1 mg of adrenaline, which is in a dilution of 1 in 1000. So 1 ampule has to be opened and it is to be loaded in a 10 cc syringe, diluted till 10 cc. So the dilution becomes 1 in 10,000, and you have to give it intravenously. After giving as a bolus, after that give bolus of 10 to 20 ml NS, and raise the hand through which you have given the adrenaline like this, and keep it raised for approximately 10 to 20 seconds. This has to be repeated. You can give adrenaline every 3 to 5 minutes. In case of refractory ventricular fibrillation or ventricular tachycardia, we use other two drugs. First is amiodarone. 1 ampule of amiodarone contains 150 mg of the drug. So we'll be requiring 2 ampules. So it will be open 2 ampules, load 300 mg, dilute it in 20 to 30 ml, and give it intravenously. And you can even repeat the drug 150 milligrams in 3 to 5 minutes. Next comes is lignocaine, that is also used in refractory VF or VT. Initial loading dose is 1 to 1.5 mg per kg, followed by second dose that is approximately 0.75 mg per kg. You can repeat it in 5 to 10 minutes. Now, just to reiterate, adrenaline forms the mainstay. And in refractory cases, class 3 antiarrhythmic, that is amiodarone, is given. Next, atropine is given if the patient has been revived, but his heart rate is not maintaining. He has got bradycardia. So in that case, we'll be giving 0.64. 1 ampule has 0.64 mg of the atropine, and you can give it up to a maximum of 3 mg. Now, next is flumazenil. Now, in certain cases, the patient has taken benzodiazepines. There is benzodiazepine like midazolam overdose. So in that case, it is the antagonist that is used. Next is naloxone. It's an opioid antagonist used in case of fentanyl toxicity. Soda bicarbonate, these are the other drugs that can be used in ACLS after you have diagnosed the conditions leading to the cardiac arrest. So soda bicarbonate has been used for pre-existing metabolic acidosis, and vasopressin, actually it was initially used as a part of ACLS, but since 2010 we have stopped using it. Along with the adrenaline it was used, but it doesn't provide any further advantage, so it has been removed. Now, if we all of us use local anesthetics in our OPD or even our OTs are for doing various procedures under local anesthesia. So if there is LA toxicity, in that case, the patient is going to have convulsions. So what do we do regarding that? So we will be terminating the convulsions induced by LA by using midazolam. And in such cases, patients will be requiring assisted ventilation, like on ventilators and circulatory support, if there is cardiac toxicity is too much, and it will be required, which is a part of ALS protocol. Now, this is just a CPCR technical review. So I've already covered all these points. First, we'll be recognizing that there is no pulse and no breaths, not taking more than 10 seconds. The next sequence of CPR is CAB, that is circulation, airway, and breathing. The compression rate of chest compression rate should be 100 to 120 per minute. Compression depth should be 2 to 2.5 inches, and you should always allow for the chest wall to recoil completely in order to heart to fill up with blood for the next chest compression. And minimal chest compression interruption should be there. The ratio airway to be opened by head 3 maneuvers, chin lift, head tilt, and jaw thrust technique, and the compression to ventilation ratio should be 30:2. In case of pediatric CPR, if it's a single rescuer, we'll be continuing with 30:2 ratio. But if it's a two rescuer technique, then we'll be giving 15:2 chest compressions, because the respiratory rate in children is higher as compared to adults. Then ventilation with advanced airway. In case of, like, we have placed an endotracheal tube and we are going to give the rescue breath. So in that case, your ventilation will be asynchronous with the chest compression. So one person is going to continuously give chest compressions, while the other one, ambu bag attached to your ETT, will be giving rescue breaths at a rate of 10 breaths per minute. And last one was defibrillator. Okay, next, this is the chain of survival. We've like in previous slides also you've seen this. We want to just reiterate this chain of survival. We have to prevent the arrest, perform early CPR, activate EMS, advanced life support, and post cardiac arrest care. So what is in our hands? Prevent arrest and perform early CPR. So everyone should, it is critical for all of us that we should be thorough with the CPR techniques, and multiple workshops are available for doing the same. Be safe, do no harm. Thank you.
I would like to invite our next speaker, Dr. Amruta Hippalgaonkar Bokil. She has done MBBS and MD and DNB in anesthesia in Lokmanya Tilak Municipal Corporation, Sayan, Mumbai. She has done fellowship in pain management from Sir Gangaram Hospital, New Delhi. She is doing freelancer anesthesia in Satara since 2017. She is assistant professor in Government Cancer Hospital since from 2014 to 15, and in LTMMC from 2015 to 17. She is attached to KIMS Karad since 2017 till date. She has published 8 case papers, and she is a life member of our ISA. So I invite Dr. Amruta to deliver her next lecture.
Thank you, madam. Good afternoon, one and all. Airway management. Aren't these pictures scary? So is the need of topic, that is airway management. Airway management is of importance in cardiopulmonary resuscitation, intensive care medicine, emergency medicine, as a first aid, and in anesthesia. Anesthesia is nothing without airway management, and anesthesia is nothing but airway management. Why we have to worry so much about airway management? What airway management, if there is lack of oxygenation and ventilation, what does it lead to? It leads to hypoxia and its various consequences like death, brain injury, cardiopulmonary arrest, unnecessary need of surgical airway, airway trauma, damage to teeth. So managing difficult airway is always a challenge. Managing has become simple with the advent of new devices, new concepts, increased awareness, and airway management guidelines. Though there are various guidelines available, we have to modify these guidelines according to our own setup. This is the overview of the Difficult Airway Society guidelines which have been given. The plan A shows face mask ventilation and tracheal intubation. If this fails, you have to go for a second plan B, that is supraglottic airway devices. In case of failure with these devices, you can go with again a final attempt to face mask ventilation. And if unfortunately all this fails, that is cannot intubate, cannot oxygenate situation, then you have to go with front of neck access, that is cricothyrotomies. Overview of the anatomy of larynx. As you can all know, the oropharynx, the hypopharynx, the laryngopharynx, and a laryngoscopic view of the same. What are the equipment? We always have to be ready with armament, that is an oxygen source, a bag mask ventilation capacity and capability, laryngoscopes, that is direct and video laryngoscopes, the several types and sizes of endotracheal tubes, other non-endotracheal tube airway devices like LMAs, oral airways, nasopharyngeal airways, a fully functional suction, which is of utmost importance, and other monitors like pulse oximetry, the echocardiography, blood pressure monitoring, and end tidal CO2 monitoring. First, we begin with airways. Now, what are these airways? Airways are medical devices which, when inserted either into oropharynx or nasopharynx, help in maintaining the patency of the airway and help in unobstructed breathing. They all do this by preventing the tongue from covering the epiglottis, which could prevent the patient from breathing. This is the oropharyngeal airway. They are available in various sizes. It has three parts: the flange, the bite block, and the curved portion, which helps to push the tongue forwards and prevents the epiglottis from falling in the posterior pharyngeal wall. The nasopharyngeal airways, they are available in red rubber as well as PVC with a flange, with adjustable flange, and specialized with O2 tube also, so that we can continue oxygenation while using these airways. How do we insert these airways? First, how we select the size. The size of oropharyngeal airway is selected by putting the airway from the angle of the mouth to the angle of the mandible. If the airway is too short or too large, it can again cause obstruction. So you have to be very careful with selecting the size of the airways. You have to put the airway with the curve facing to the hard palate and then rotate it by 180 degrees so that it is fixed in place. The flange of the airway, which we can see, rests on the lips. So is the case with the nasopharyngeal airways. You have to select the size from the tip of the nose to the tragus. You have to insert it by keeping the airway up to from the floor of the nose. Do not go it more anterior or posterior. Now, after the airways, what we see always when we think of airway management, we always go ETT holds supremacy. As we can see, ETT is above all these other laryngeal mask airway devices. So we have to discuss here what is endotracheal tube. So endotracheal tube, here it is available. Nowadays, they are PVC tubes, transparent tubes available with a universal connector. They are cuffed or uncuffed tubes. Various formulas are available for selecting the size. Usually for females, the size is about 6.5 to 7.5, which you can use. And for adult males, it is 7.5 to 8.5. Ideally, while choosing a tube, you should see that the external diameter of the tube is the same as the width of the patient's distal end of the little finger. A few lines or a few words about the ETT cuff. ETT cuff, it provides a seal between the tube and the tracheal wall to prevent aspiration of the gastric contents. It prevents the air leak. It serves to center the tube in the trachea, and it can be a high pressure, low volume cuff or a low volume, high pressure cuff. Nowadays, we usually use the high volume, low pressure cuffs. The older ones with the red rubber tubes, they use the low volume, high pressure system. Now, usually the high volume, low pressure cuffs, they center the cuff in the center of the trachea. Hence, they exert a less lateral pressure, causing less mucosal injury. Usually, the recommended cuff volumes, cuff pressures are 20 to 30 centimeters of water. And for that, according to a study in 2012, it is shown that hardly less than 5 ml of air is required to fill the endotracheal tube cuff. Now, the equipment which is required to intubate a patient is a laryngoscope. These are available in various sizes. The handles are also in various sizes. Usually, we use the curved blades, that is the Macintosh blade and the Miller blade. Now we have seen the equipment. Now we will see what is the ideal position for intubation. You have come across all these positions. We can intubate in all these positions, but the ideal position is a sniffing position, that is head elevated on a pillow or a head ring and the head extended on the neck. Why is this position important? Because the oral axis, the pharyngeal axis and the laryngeal axis, all these three axes come in a straight line and thus help in proper intubation. Hence, a sniffing position is ideal. But in case of cervical injury, where you cannot provide this, you have to adjust it. Now, this is a lateral view of how we intubate the patient using a Macintosh and a Miller blade. And if after a sniffing position, you cannot get a proper view of the larynx, you can do external laryngeal manipulation. These are the various types of endotracheal tubes, a north polar tubes, the south polar tubes, which are used in various maxillofacial surgeries. A south polar tube is used in cleft lip palate surgeries. A tube with camera at the end has been recently added, where you can see the movement of the vocal cord even after our thyroid surgeries, where it is very important to see the movements of the vocal cords. Endobronchial double lumen tubes, these are used in lung isolation surgeries. Microlaryngeal tubes, these are used in cases of lesions in the larynx on vocal cords, where you cannot intubate the patient with a large adult tube because it may hamper the view of surgeon and surgeon's axis. Armored tubes, these are wire reinforced and endotracheal tubes, which are flexible and they give strength plus flexibility to the tubes. These are the tubes which are used in laser surgeries because laser can be inflammable, and hence a simple technique is just covering the red rubber tubes with a aluminium foil. That will help. A high success rate, low cost intubation aid is a bougie. They are available in ventilating and non-ventilating forms. These are usually it helps in intubation. Now, we know how intubation can be done. We know how back mask ventilation can be done. But if either of it fails, now what comes to our rescue is that a supraglottic device. A supraglottic device helps oxygenation and ventilation, but prevents the difficult airway and helps in difficult airway situations. They can be used as a primary airway device, a rescue device, or they can aid in difficult intubation. They are useful in resuscitation and pre-hospital airway management. They also help in as an extubation aid and for procedures like bronchoscopies and percutaneous tracheostomies. According to their evolution, they are classified as first generation with simple airway tubes, examples being classic LMAs, flexible LMAs, LMA unique, and the second generation, which include a drainage tube along with airway tubes, that is ProSeal LMA, iGel, SLIPA. The third generation, which they are recommended, they use a 2 drainage tubes, cuffless, and a small ball, that is a Buska mask. Now, what is the main difference according to our thing is, first generation supraglottic airways, they prevent the air leak when the positive pressure ventilation goes up to 16 to 20. But what is the advantage of second generation is that they maintain the pharyngeal seal even with pressures of 25 to 28. Hence, they are even more rescue devices and definitive airway devices. Now, this is a classic LMA, which you can see it has an airway tube, a mask with aperture bars, an inflating bulb, inflating line with a pilot inflation balloon, and a one-way valve. The second generation ProSeal, as you can see, it has an incorporated bite block, a gastric drainage tube, and no aperture bars. And the cuff is also deeper and larger with no grills, and it has an incorporated bite block. Now, how we insert an LMA? An LMA, you have to hold the LMA with like a pen with an index finger between the junction of the airway tube and the mask, glide it along the hard palate, push it inside the hypopharynx. Still a resistance is encountered and with the other hand, you have to stabilize it, remove the finger, fill the air and see for ventilation with an umbu bag with chest rise, auscultation, and definitively with the ETCO2. These are the other various types of LMAs. Just to list it, LMA unique, which can be used only a single-use LMA. Disposable LMA, LMA flexible, again like an armored tube. This is a reinforced LMA, so it is a flexible, can be used in head and neck surgeries. The LMA fast track, which helps in intubation. They have a pre-angulated curve, as you can see. Hence, there is no need for insertion of a finger during insertion of these LMAs. They already have an angulated things like an LMA Supreme. These are other, the LMA fast track and Supreme are second generation LMAs. Ambu Aura family is again a second generation LMAs. Then Ambu Aura Gain, the left one which you see, and the second, the below left one, that is an Ambu Aura Gain, which has a gastric channel and an intubation gate. The most interesting nowadays you can see in all the OTs is the iGel. Now iGel, it can be inserted like a soup spoon. The mask is made up of medical grade thermoplastic elastomer. It adapts to the patient's airway, anatomical seal of the pharyngeal, laryngeal, and perilaryngeal structures. So it provides an effective seal without a cuff. It doesn't have chances of hyperinflation because we do not have to inflate the cuff. It has an integrated bite block. It has an epiglottic rest, which prevents the downfolding of the epiglottis. And it is available in various sizes. The sleeper mask, second generation, again, it is like a sleepers. It is a hollow boot-shaped mask which fits into the perilaryngeal and pharyngeal structures. The third generation is a Buska mask. Now here's a Combitube, which also can be used during resuscitation. It is a pharyngeal sealer. It is also known as a blind airway device. You can insert it either into the esophagus or in the trachea. You can ventilate the patient. Now, what are the contraindications? As such, there are no contraindications, but relative contraindications being like mouth opening less than 1.5 centimeter, poor lung compliance, patients with increased risk of aspiration, a non-fasting patient, patient with massive maxillofacial trauma. These are relative contraindications. Now, this is the crux of the LMAs. You can see in the scorching heat of deserts with the poisonous snakes rattling around you, still the LMAs are relaxing and hence the anesthesiologists are also relaxing with these LMAs in place. A few words about the video laryngoscope. Images transmitted to the LCD display through the video system. It is an indirect laryngoscope. It has a handle, blade, and a micro video chip camera at the end. Now, these are available with integrated tube channels and not integrated tube channel. It is a glidescope, a McGrath laryngoscope, Air Track, which is a channeled video laryngoscope. King's Vision, it comes in both channel and non-channeled blades. A CMAC video laryngoscope. Now, what are the uses of these video laryngoscopes? They are simple to use, no wires, portable, low cost, easy to insertion, no damage, good exposure, non-problematic tube passage, works well with restricted neck movements, restricted mouth opening. Fogging is not a limitation. They can be used in morbid obese patients also. Now, this is very interesting. Flexible fiber optic bronchoscope in patients with unstable spine fracture spines or poor range of motion into temporomandibular joints, anomalies, where video laryngoscopy or direct laryngoscopy is not possible, then you can go with flexible fiber optic bronchoscopes. But the main disadvantage of this is it is very expensive and very expertise is required. Learning curve is more, and these instrument is very delicate and hence difficult for maintenance. The future of anesthesiologists is a robotic intubation, where one day will come where anesthesiologists will sit in the console, remote location, and intubate the patient. The slide which I had shown, the fourth plan D, that is surgical airway techniques, the cricothyrotomy and tracheostomy. It is a needle cricothyrotomy just to oxygenate and ventilate the patient in severe respiratory distress, temporarily secures the airway. Needle cricothyrotomy set, which is shown in the picture, can't intubate, can't ventilate situation. Scalpel cricothyrotomy, where you have the 3 steps only: scalpel, bougie, and tube. Helps in ventilation and oxygenation of the patient. Last slide about the suction catheters, because overzealous suction may lead to atelectasis, initiating bronchospasm. So you should be very careful while choosing the suction. The diameter of the suction catheter should be less than half of the inner diameter of the tube. Ideal suction pressure should be adult suction pressures 100 to 200 millimeters of mercury. Children much more less, that is 80 to 100 millimeters of mercury. Usually we use the green colors or the white colors, that is yellow or 14 French for adult females and 16 up to 16 for adult males. Thank you very much. Knowledge empowers you. And if you are not willing to learn, no one can help you. But if you are determined, no one can stop you. Thank you so much for patient listening.
Now I invite our last speaker, Dr. Madhuri Limay, madam. She is a dynamic president of ISA Satara. She is practicing anesthesiologist for last 34 years. Such a vast experience. Working in Satara Anesthesia Association since 1988. She is a secretary of ISA Satara from 2008 to 2014. And now she is president of ISA Satara. She is also MMC observer. She is IMA Central Council member, IMA Ladies Wing Council member. She has been invited as a faculty and chairperson at many district, state and national conferences. Anesthesia awareness and CPR training programs for last 14 years. For this work, she has received many prizes and at state and national level for Satara branch and individual also. Okay. She has worked as an anesthesiologist as various operative camps in the past at Rotary Camp, Lilamati Hospital, Mumbai, Hemal Kasa and Lok Biradari project by Dr. Prakash and Mandatai Amte. Shodhagram project. Shodhagram is a project by Dr. Abhay and Dr. Rani Bang. So I invite Dr. Madhuri Limay, madam, to deliver her last speech. And I congratulate all our speakers for their brilliant talks.
Thank you, dear Vaishali, for kind introduction. And now Dr. Amruta has told about the future in anesthesia, but coming back to earth, परत एकदा जागेवर येऊया. What to do in special situations, like simple situations, fainting, syncope, vasovagal attack, road traffic accidents, drowning and choking. Coming to the fainting, syncope, vasovagal, whenever we see a patient dizzy, yawning, profuse sweating, restless, blurred vision. So what are the causes of this? Something pain, anxiety, something frightens or horrified sight. To our interest, it is while giving intramuscular, intravenous or local infiltration of, or while giving spinal anesthesia. And this, all the fainting, syncope or the vasovagal attacks can be mistaken as the anaphylaxis. But that reminds me that anaphylaxis presents very differently. So what is the treatment of fainting, syncope and the vasovagal? Obviously, no serial or cinema show like that. की कांदा, पाणी, चपला ते आता सगळं संपलेलं आहे. पण पाणी आणणारे, चहा आणणारे, साखर आणणारे, तर ते द्यायचं का नाही आपण बघू. Elevate the legs, simple. Because all these symptoms are, brain is giving signal that I need glucose, oxygen. So whenever brain gets less blood supply, all these symptoms occur. So elevate the legs and then see the consciousness. If patient is conscious, then only give water or liquids. And if patient is unconscious, immediately start CPR. So no oral to unconscious patient and no CPR to conscious patient, obviously. This is just what we saw, fainting first aid. Now coming to the road traffic accidents. हे नेहमीच आपला सीन आहे. India tops in road deaths. Of course, this data is of few years ago, but one accident every minute, one death due to accident every 4 minutes, and accident will be the 5th major cause of death in India. So causes being poor enforcement of helmet. सक्तीचं केलं आहे तरी. No seat belt wearing, even especially back seat. ह्याच्यावरनं मला आठवलं की हल्ली बऱ्याचशा व्हेकल्सला अलार्म दिलेले आहेत सीट बेल्ट नाही लावला तर. पण असेही हुशार ड्रायव्हर आहेत की जे आधी सीट बेल्ट लावून बकल करून टाकतात आणि नंतर त्याच्यावर बसतात. जस्ट टू पुट द अलार्म ऑफ. आपल्याकडं अशा हुशार लोकांची काही कमी नाही. हाय स्पीड, consumption of alcohol, deadly roads, and inadequate ambulance facility and pre-hospital care. So the most important thing is all these causes are preventable. And in the road traffic accident, death is due to brain injury or bleeding, either external or internal. The serious part is 80% are alive at the accident site. Remember, 80% are alive at the accident site, but usually we lose our golden period and we lose many precious lives. And 70% are younger ones. So what is the situation at road traffic accident? This is the common situation. All present at the site are intending to help, but nobody knows what and how to do. No organization, no plan of management, no teamwork. Everybody doing as per his wish and knowledge, and everybody is in a hurry. This help will be more dangerous. Whenever we want to go for help, just legal issue comes in mind. So this is the statement from Supreme Court, that any person who meets road accident can be taken to the nearby hospital immediately. Hospital must not ask for police report to admit him. It's doctor's duty to do first aid. Police can be informed later. Just now we saw in COLS that ensure safe place, especially in road traffic accident. If the victim is in danger, use one of these methods to move the victim. About the spine stabilization, whenever there is a head trauma, broken collarbone, polytrauma, do not shake or tap on the face to elicit response to see the consciousness. This may cause movement at the neck, which could harm victim with cervical spine injury. So what to do in cervical spine injury? Spine stabilization. Steady the head, being careful not to pull at the neck. And give support with folded clothing. Do not move the casualty from position found unless he or she is in danger or becomes unconscious. Now, just now we saw time is life, and we have maximum 10 minutes after heart has stopped. Every minute decreases the chances by 10%. So time and life are the co-teachers. Life teaches us the use of time. Time teaches us the value of life. Now, just now, Vaishali told about the IRC guidelines, because in Western countries, ambulance occurs within 6 minutes. It is well equipped. First aid training is compulsory for every 10th class student. In India, very different situation. These callings we saw just now, this is applicable in every case, in case of drowning, in case of road traffic accident, everything. Just ensure safe place, then see the consciousness. If patient is unconscious, call for help. Then dial 108 or ambulance and start CPR. Now coming to the drowning. It is death secondary to asphyxia. Primary, there is asphyxia. While immersed in liquid, usually water, within 24 hours of submersion. Then what to do in drowning? Air hunger and patient is usually panic, which leads to reflex inspiratory efforts, leading to aspiration of water and laryngospasm. Asphyxia and hypoxemia leads to acidosis. Asphyxia, if laryngospasm is maintained, it gives respiratory arrest, leading to cardiac arrest. It is called as dry drowning. And when the airway is relaxed, water enters the lungs. There is a surfactant washout. There is ventilation perfusion mismatch. It is wet drowning. This is a gasp reflex leading to hyperventilation. This gasp reflex leads to panic, aspiration, and drowning. Decreased CO2 leads to respiratory alkalosis, cerebral vasoconstriction, and possible convulsions. Now, cardiac response to cold stress in the first few minutes. It may be total body immersion or face only immersion. If there is a diving reflex, it decreases heart rate, decreases cardiac output, increases mean arterial pressure, and because of increased total peripheral resistance. And if there is a no diving reflex, there is sympathetic activation due to temperature of water, increased heart rate, increased BP, and cardiac arrhythmias. So the essential first aid management as a routine, see if the patient is conscious. If no aspiration, just observe it. If aspiration, give oxygen and transfer to the hospital, because aspiration can cause late complications, neurological, pulmonary edema, pneumonia, DIC, hemolysis, hepatic and renal failure, and the bowel necrosis. Also complications of hypothermia. And if patient is unconscious, just now we saw CPR with 100% oxygen and immediate transfer. Now, in case of drowning, it is advised to give 2 rescue breaths, either mouth to mouth. How to give it? Pinch the nose, take normal breath, place lips over mouth, blow until chest rises, just for 1 second, allow chest to fall, and then repeat. This is how mouth-to-mouth respiration given. We can give mouth-to-mask respiration. Some masks to give mouth-to-mask respiration are available at outside stall. You just can view that. And now, if the patient is unconscious, start CPR. So this is the flow chart. 2 initial breaths, then wait for the end of expiration. 10 to 12 breaths. Just now we saw it. Control over ventilation and check air return. Now the condition is choking. Obviously, मला वाटते कोणालाही अशी वेळ आलेली नाहीये choking हे revive करायची, but we must know it. What is choking? It is the foreign body airway obstruction. In mild, there is a good air exchange. Patient can cough forcefully and patient may wheeze. If it is severe, there is no or poor gas exchange, ineffective or no cough, high pitched noise while inhaling, and respiratory difficulty and cyanosis. Patient is unable to speak with universal choking signs. What are these? Cough, breathlessness, retrosternal discomfort, cyanosis, tachycardia, tachypnea, wheeze or crackles in the chest, pink from the sputum, and reduced consciousness. So how to relieve the choking? If it is mild, encourage patient to cough and breathe and monitor. Call ambulance if problem continues. If it is severe, call ambulance and perform Heimlich maneuver. In infants, do not use abdominal thrust, and in pregnant and obese patient, use chest thrust. So what is hemorrhage maneuver? Stand or kneel behind the victim with arms around the victim's waist. Make a fist, place it above the navel and below the breastbone in the midline. Grasp the fist with another hand and press into the victim's abdomen with quick upward and inward thrust. Repeat till the object is expelled, or if patient is unresponsive, go for CPR. This is the maneuver to do. These are the steps of hemorrhage maneuver. So we are supposed to lift the patient with our two fists with pressure backwards, upwards. This is the self-hemorrhage maneuver. When there is nobody around, we can do self-hemorrhage maneuver, that stand at the edge of a chair with the area in between our umbilicus and episternum, touch to the chair and just give inward and upward thrust. This is for the children. Now choking in the infants. We are not supposed to give any abdominal thrust. So if the infant is responsive, kneel or sit with infant in your lap. Hold the infant prone on the forearm. Excuse me, signal का होतो? Off करा जरा. Timer आता. So the relief of choking in infants, kneel or sit with infant in your lap. Hold infant prone on the forearm, resting on the lap with head lower than the chest. Deliver 5 back slaps forcefully, sufficient to dislodge foreign body between infant shoulder blades using heel of a hand. And again, turn infant on its back with support of forearm and give 5 chest thrust at the rate of 1 per second. The chest thrusts are given on the lower half of the sternum. If the infant is unresponsive, obviously we must start CPR. So place on a flat surface, open airway, remove the object if visible, but please do not perform blind sweeps. Otherwise, object will go inside. CPR with one extra step, that each time we open the airway, check for the object. 5 cycles of CPR and activate emergency services. So this is the technique to do with the infants choking. 5 back slaps and 5 chest thrust. And the immediate hospital management will be, as usual, assess and manage ABC, 100% oxygen, pulse oximetry, all the monitors, ABG, and urine output, chest X-ray, observation, and management of associated hypothermia. Thank you, dear friends, for patiently listening our workshop. We, ISA Satara, feel that it is the purity of the heart that matters, not the external appearance, because helping hands are always better than praying. So thank you very much. One announcement, please. एअरवे वर्कशॉपचे थोडेसे ऍडव्हान्स LMA आणि हे बाहेर टेबलला डिस्प्ले केलेले आहेत अंबू कंपनीने, आणि तिथे व्हिडिओ लॅरिंगोस्कोप पण आहे आणि फायबर ऑप्टिक पण आहे. यू कॅन जस्ट हॅव हँड्स ऑन इंट्युबेट तुम्ही करून बघू शकता ऑन द मॅनेकिन. त्याच्या आधी आपण एक इथं क्विक COLSचा रिव्ह्यू घेऊया, कारण मला वाटतं बऱ्याच लोकांना तो ऑनलाईन दिसलेला नाहीये. तर इथे 2 मॅनेकिन्स ठेवलेले आहेत. आमचे 2 कलिग्स येऊन इथं तुम्हाला क्विक स्टेप्स दाखवतील COLSच्या. So we will start with the patient collapsing. थोड़ा सा vertical करा. So we found the patient Patient is collapsing. So this patient has collapsed. What will be the next step? Ensure safe place. Obviously, on the road or near the flood, we are going to take the victim to a safe place. Then make the patient lie down. First step will be elevate the legs. We can't show it here, but just to improve the blood supply of the brain. And then check for the response. Please check for the response. Tap on the shoulder, not face, no neck movements, please. Tap on the shoulder and give any command. Show your mouth or show your tongue. Please open your eyes. So there is no response. So what next? Please call for help and ask somebody to dial ambulance or 108. After that step, we will start our chest compression immediately. Because just now we saw, we have within 3 minutes, we have to start the chest compression. Now, what will be our position to give the chest compression? It is standing on the knees, not sitting, not leaning, not standing, standing on the knees. Now, where we are going, let us see the position of our hands. Our hands position will be like this, the fingers interlocked. We are giving the compression with the heel of our or thinner hypothenar ambulance. No bend or flexion at the elbow, and our hand must be in a straight perpendicular direction to the patient. Now where to give the compression? The site of compression will be 2 fingers above the episternum, or simpler way, in between the nipple line, in the midline. Now, the rate of compression will be around 2 per second or 100 to 120 per minute. And the depth will be about 5 centimeter, about 1/3 of the chest. So we'll start compression now. See, while compressing, we have to give release of our pressure because the heart has to fill in. What we are achieving with this compression? So we are pushing the blood supply to vitals like brain and the heart. So how many? I think that has been covered. Where to start? Yeah. Video Now, one of our colleague, Rajan Joshi from Thane, has made a very beautiful video about COLS. So, after vote of thanks, we'll see that video, and then we request all of you to come forward and do hands-on.
Good evening all. I am here to give a vote of thanks on behalf of ISA Satara to Dr. Sharad Jagtap sir, President IMA Satara, Surya Kumar Khandare sir, to give ISA a chance to present this workshop, including COLS, BLS, airway management, treatment of choking, and pain management by Dr. Barge Madam. I thank all the office bearer of IMA for the same. I thank all the online and offline attending doctors. I thank all the audiovisual management by Shakil Sheikh. I thank all the speakers of this ISA Satara, Dr. Lime Madam, Dr. Vaishali Chauhan Madam, Dr. Barge Madam, Amruta, Dr. Mugdha, and the volunteers, Dr. Parimal, Dr. Mrunmai Divekar. I thank all and every member in this hall. Thank you very much. If anyone wants this chest compression hands-on training, please come forward. Our members can tell you the bag max ventilation, chest compression, or all the airway equipments we have brought here, defibrillator, and there is a advanced management, that is LMA, and IGL and fiber optic bronchoscope they have brought. You can see and take a demo from that person. Thank you all.
में आग में या आग में तालाब में उस जगह से उसको दूर लेना है क्योंकि खुद को पहले महफूज रखना है उसे जगह उसे बुलाओ एक बार कि सांस बंद है क्या देखो मेरे यार मदद के वास्ते पुकारो जोरदार 108 डायल करो यार
हेलो
एक मिनट मैडम
Hello. This is IGL. Jelly lawaयचे directly. So these are not getting manicures. So. ऐसे टाकून ह्या इथे येतात. Hello. नाही त्यात नाही मॅडम दॅट इज हॅलो
मॅडम ज्योती मॅडम
हॅलो हा
After this, we will felicitate workshop faculty member. Then after there will be inauguration of workshop. So please don't go. Remain in the hall till the next workshop starts.
हॅलो हॅलो Mugdha is demonstrating the use of defibrillator. This is a intubating mannequin. You can try LMA, iGel. This is video laryngoscope they are demonstrating. तुमचं नाव काय?
कॅमेऱ्यावरती काही दिसत नाही. एक दोघांना घ्या एक दोघांना घ्या.
हॅलो Now we are going to demonstrate your larynx on this intubation. We have that is chest compressions on this body. These are the mannequins. These are the intubating mannequins. Sir, want to do chest compression? Please come. Mr. Chandashe will show us the demo of video laryngoscope on this intubating mannequin. These are the advanced technologies.
Good evening all. So I am representing Ambu. So we have King Vision video laryngoscopes as we now seen in airway management, how it is important. So as Ambu, we have King Vision, we have two blades. One is channel blade and second is non-channel blades. So channel blades are you can preload your ET tubes up to 6, 6.5 and 7. And this above 7 size, you can enter your ET tubes with stillet. Okay.
Two parts of this video laryngoscope. On off button is there. Video laryngoscope is on. We are applying this video laryngoscope in this intubating mannequin. Just insert in the mouth up to the insert this video laryngoscope in the mouth up to posterior third of tongue. You can see the cords, these pearly white vocal cords. We can see easily in this intubating mannequin. Then we can intubate easily. The tube is loaded on this video laryngoscope. Copy is done. These are pearly white vocal cords. Under vision, we can finally intubate this patient with this ETT. Intubation has been done with this endotracheal tube. You can bag mask with this. You can see lung inflation. That is, tube is properly we can see the inflation of these lungs. If anyone want this chest compression on mannequins, or if you want to see this video laryngoscope on this intubating mannequin, please come forward to demonstrate.
Sir.
Oh, nice. Dr. Chaitanya is demonstrating how to use iGel in this intubating mannequin.
Last 10 minutes for this workshop. We have to proceed for inauguration and next workshop. So
iGel, sir.
last 10 minutes.
This is iGel.
Anyone having questions, please ask simultaneously. If anyone has questions, please ask.
Madam, I am having question. My question is, madam, whether these equipments are used only for anesthetist or general surgeons and other clinical person can use these type of scopes in his clinical practice. One question. And my second question is whether how to use these type of scopes in the pediatric age group.
So very good question. Actually, our intention is everybody must know ventilation. And we know that intubation is not easy. So we are coming with this airway devices. So these iGel and supraglottic devices, you
Please
can
keep quiet.
insert as the
Audience,
airway
please.
and you can easily ventilate the patient. And about the
Requesting.
pediatrics, there are different blades and different tubes.
Hello.
Please keep silence, please.
Hello.
I request
keep
all the
silent.
members to please.
Hello. All delegate, please keep silence in hall.
Hello, Dr. Jagtap sir has one query, whether all these devices are only for the anesthesiologist. So our intention is everybody must know ventilation. And so we have come up with these all airway devices that anybody can insert like airway and ventilate the patient to save our lives. And the second question was about the pediatric. So there are different airways and supraglottic airways are available in pediatric size, but not just now. So here we can intubate with video laryngoscope on adult only.
Last 5 minutes. Everyone from stage, you can practice demo outside on table. We have made special arrangement for that. Last 5 minutes for current workshop. Last 5 minutes. Now this we are concluding first workshop of anesthesia team Satara. I welcome Dr. Surya Kumar Khandare, President, Dr. Sharad Jagtap Sir, Secretary IMA, to please come on stage and felicitate the anesthesia team. I request Dr. Madhuri Lime, Madam. Dr. Madhuri Lime will get felicitated by Dr. Surya Kumar Khandare, Sir. Dr. Vaishali Chavan, Madam. I request Dr. Surya Kumar Khandare, Sir, felicitate Dr. Vaishali Chavan, Madam. I request Dr. Sharad Sir to felicitate Dr. Jyoti Moite, Madam. Dr. Jyoti, Madam. I request Dr. Vibhavari Patil, Madam, please come on stage. I request Dr. Sharad Sir to felicitate Dr. Amruta Bokil, Madam. I request Dr. Vibhavari Patil, Madam, to felicitate Dr. Mugdha Mahajan, Madam. Dr. Mugdha. I request once again to felicitate Dr. Asha Barke, Madam. There are two volunteers for this anesthesia workshop, Dr. Yavatkar Sir, Dr. Parimal Yavatkar Sir, Dr. Sharad Jagtap Sir will be felicitate Dr. Parimal Yavatkar Sir. I will request Dr. Munalini Divekar to come on stage. Dr. Surya Kumar Khandare Sir will be felicitate. Dr. Chaitali Thorat, please come on stage. Dr. Sharad Sir will give felicitate. Dr. Sharad sir to Dr. Chaitali Thorat madam. Thank you, anesthesia team, for wonderful scientific academic session workshop. It's like super hit workshop for today's. So we will progress for inauguration of workshop. To do our duty, and doing duty brings happiness. So we are here to get knowledge which turns ultimately into happiness. Today we have workshop inauguration. Our inauguration chief guests, I request Dr. Surya Kumar Khandare, President IMA Satara, to escort chief guest on the dais. I request Dr. Vikas Patil, past President IMA, Dr. Lahoti sir, Jeevan Lahoti sir, past President of IMA, and Dr. Madhuri Lime Madam, President of Anesthesia Satara team. Come on dais. Dr. Surya Kumar Khandare sir will escort them on stage. Welcome Dr. Jeevan Lauti sir, Dr. Vikas Patil sir, and Dr. Madhuri Limbe madam. Please have a seat on dais. I welcome Dr. Sharad Jagtap sir, Secretary. I request all respected guests मी सर्व मान्यवर उपस्थित I request all delegates to be on the hall. Who are taking tea outside, please come inside. We are starting inauguration program. So I request all delegates, please sit in hall. We are starting inauguration program. मी डायसवर उपस्थित सर्व अतिथी आणि IMA प्रेसिडेंट सेक्रेटरी यांना विनंती करतो की त्यांनी धन्वंतरी पूजन करून पुष्प अर्पण करावे. धन्वंतरी पूजन आणि पुष्पार्पण यासोबत we are saying IMA prayer. May everybody be happy. May everyone of us see to it that nobody suffer from any pain or sorrow. I do not ask for crown, nor I wish to be heaven or reborn. I only want to eliminate suffering of those people who are burning in fire of sorrow. Long live IMA.
हॅलो. धन्वंतरी पूजन, दीप प्रज्वलन आणि सरस्वती स्तवन. या कुंदेन्दुशारहार धवला या शुभ्रवस्त्रामृता या वीणावर दंड मंडित करा या श्वेतपद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
I now request President Dr. Surya Kumar Khandare sir to give 2 words regarding workshop inaugurations. I welcome Dr. Surya Kumar Khandare sir.
Good evening, everyone. I, Dr. Surya Khandare, President, IMA Satara. Respected seniors, colleagues, and my dear friend. We have now inaugurated SATCON 2023, this program. Today, workshop topics selected are Advanced Life Support and WealthCon. We know that we are clinician doing modern medicine practice. We are facing everyday emergencies during our work. This session will enlighten us our newer method technique, not only to help or save the life. I appreciate hard work done by ISA Satara team. Surely their effort will make us knowledgeable and overcome the critical situation. Second work of chosen was WealthCon. Why? Because we are hard-working community. We know how to earn, but we are least aware of investing our money, or we are poor in financial management. We know how. This workshop will surely help us, Dr. Fidelity, to become a swan bird. Philosophy, truth, enlightened by founder of WealthCon, Dr. Ramnath Gutte. Dear friends, senior, let's together learn all saving through this workshop of Advanced Life Support and WealthCon to become a swan and newer technique. Thank you.
Now I will request Secretary IMA Dr. Sharad Jagtap sir to give vote of thanks.
Respected chairpersons and all our chief guests, I thank all of you for inaugurating this workshop. I also thankful to all the anesthesia team, ASA team, who have taken the best efforts to get this workshop very successful. I give best wishes to the next workshop session for the WealthCon who are going to conduct this second session. I thank you, all of you, for patient listening. I thanks to all the supportive team to get this program very successful. We are having 2 days of the conference in our hand. So same is expected from all of you. Thank you, everyone.
Thank you, Sharad sir. Now we have 10 minutes high tea break. After 10 minutes, we will start our next session, WealthCon workshop. So 10 minutes break. There is one pen drive. कोणाचा पेन ड्राईव्ह हरवला असेल तर एक पेन ड्राईव्ह सापडलेला आहे, त्यांनी स्टेजवर येऊन कलेक्ट करावे. अनेस्थेशिया टीम, देयर इज वन पेन ड्राईव्ह.
I've gone for last 2 to 3 years and have benefited a lot from it. WealthCon is a financial education drive for the doctors, by the doctors in a true sense. And I would recommend each one of you to come and join WealthCon and make the most of it.
Hello, friends. I think WealthCon is the only platform where doctors help each other without any prejudice or any fear of competition. There is a sense of giving back to our community in every WealthConian. Hats off to Ram sir for creating such a wonderful platform for us. Thank you.
Say that after joining WealthCon, my life has changed, completely transformed. And all this while I enjoy being a surgeon.
नमस्कार. डॉक्टर राम सरांनी लावलेला वेल्थकॉन नावाचा वटवृक्ष म्हणजे सर्वांगीण प्रगतीचं व्यासपीठच. या वटवृक्षाच्या छायेखाली आर्थिक साक्षरतेसोबतच आध्यात्मिक ज्ञान व आयुष्याचे तत्वज्ञानही प्राप्त होते. आपल्या सर्वांच्या आयुष्याला कलाटणी देणारं हे वेल्थकॉन म्हणजे जणू काही प्रगतिशील जीवनाचं दिशादर्शक होकायंत्रच होय.
नमस्कार. क्या आप यह सपना देखते हैं कि आपके साथी डॉक्टर आपकी उन्नति से बिल्कुल नहीं जल रहे और ना ही आपको नीचा दिखा रहे या आपकी चुगली कर रहे हैं, बल्कि आपके दुख और परेशानियों में आपके साथ खड़े हैं? तो आंखें खोलिए, यह वेल्थकॉन का ग्रुप है. डॉक्टरों का एकमात्र ऐसा ग्रुप जिसमें सभी एक दूसरे का हाथ पकड़े रहते हैं और एक दूसरे की परेशानियों का हल ढूंढते हैं. बिना यह सोचे हुए कि मेरे को क्या मिलेगा। धन्यवाद।
वेल्थकॉनच्या ग्रुप्सवर आहे ना अतिशय चांगल्या पद्धतीचं पॉझिटिव्ह कल्चर फॉलो केलं जातं. वेल्थकॉनचे सगळे मेंबर्स स्वॅन फिलॉसॉफीमध्ये बिलीव्ह करतात. त्याच्यामुळे त्यांच्या इंटरॅक्शन मध्ये ज्यावेळेस दुसऱ्या कुठल्या पर्सन बरोबर त्यांचं इंटरॅक्शन होतं त्यावेळेला त्या इंटरॅक्शन मधल्या पॉझिटिव्ह गोष्टी किंवा त्यांना पटलेल्या गोष्टी ते ऍक्सेप्ट आणि ज्या गोष्टी त्यांना पटलेल्या नाहीये त्या गोष्टी ते डिस्कार्ड करतात आणि दे डोंट आर्ग्यू विथ द थिंग्स. सो
Dear friends, my passive income is more than my monthly expenses. And that is what we call as financial freedom by the WealthCon way. And because of that, I'm able to pursue my hobbies without any fear of losing my monthly income. Thank you. Thank you, welcome.
वेल्थकॉन केल्यानंतर माझ्या इन्व्हेस्टमेंट्स मी स्वतः करू लागलो आणि त्यातून मला चांगले रिटर्न्स मिळू लागले. त्यामुळे मला आता फायनान्शियली इंडिपेंडेंट झाल्यासारखं वाटत आहे. थँक्यू सो मच वेल्थकॉन.
ਘਰ ਬੈਠੇ ਬੈਠੇ ਕਿਵੇਂ ਲੋ ਰਿਸਕ ਤੇ ਆਰਾਮ ਨਾਲ ਮਾਰਕੀਟ 'ਚ ਪੈਸਾ ਲਾ ਕੇ ਉਹਨੂੰ ਹੋਰ ਵਧਾਇਆ ਜਾਏ. ਕੁੱਲ ਮਿਲਾ ਕੇ ਫਾਈਨਾਂਸ ਦਾ ਉਹ ਹਿੱਸਾ ਜਿਹੜਾ ਸਾਨੂੰ ਮੈਡੀਕਲ ਟ੍ਰੇਨਿੰਗ 'ਚ ਨਹੀਂ ਮਿਲਦਾ ਉਹਦੀ ਕਮੀ ਪੂਰੀ ਕਰਦਾ ਹੈ ਵੈਲਥਕੌਨ.
Ram sir had various classes and programs and techniques, both life and financial ரொம்ப யூஸ்ஃபுல்லா இருந்திருக்கு. எப்படி கடமை பண்ணி கட்டுப்பாடுன்னு சொல்றோமோ அதே போல வெல்த்கோனோட பிரின்சிபல்ஸ்லாம் ரொம்ப
Thank you so much. Logical question था सर के.
வெல்த்கானோட தனித்தன்மையே அதனோட ரிசர்ச் விங் தான். கூகுள் ஷீட்ஸ், எக்ஸல், மாடிஃபைட் இண்டிகேட்டர் இந்த மாதிரி டெக்னாலஜி டூல்ஸை பயன்படுத்தி செல்ஃபா ரிசர்ச் பண்ணி அந்த ரிசர்ச்சோட முடிவு மூலமா மார்க்கெட் டைனமிக்ஸை இன்டெப்த்ல அண்டர்ஸ்டாண்ட் பண்ணி அதுக்கப்புறம் இன்வெஸ்ட் பண்றதுனால தான் அவங்களுடைய சக்சஸ் ரேட் அதிகமா இருக்குன்னு நினைக்கிறேன். தேங்க்யூ.
എനിക്ക് എൻ്റെ ഫൈനാൻസിനെ പറ്റി ഒരു ഐഡിയ കിട്ടി. എന്താണ് പേഴ്സണൽ ഫൈനാൻസ്, എന്താണ് മ്യൂച്വൽ ഫണ്ട്, എന്താണ് ഷെയർ മാർക്കറ്റ്, എന്താണ് ഇൻഷുറൻസ്, എത്ര ഇൻഷുറൻസ് എടുക്കണം, എങ്ങനെയാണ് ടാക്സ് ഫയൽ ചെയ്യേണ്ടത് എന്നൊക്കെ ഒരു ഡോക്ടർമാർക്ക് ആവശ്യമുള്ള കാര്യം ડોક્ટરમાર્ક മനസ്സിലാകുന്ന രീതിയിൽ എനിക്ക് അറിയാം.
આનાથી ફક્ત ફાઇનાન્સ શીખવા નથી મળતું પણ ઓવરઓલ પર્સનાલિટી ડેવલપમેન્ટમાં પણ ખૂબ મદદરૂપ થાય છે. જેમ કે જે પણ એમાં ઇન્ક્લુડ થાય છે એ લોકોને એક ગીવરની પ્રવૃત્તિ, જેમ કે બીજા લોકોને મદદરૂપ થવું, એક ડેડિકેશન કે ના આપણે ટાઈમસર કામ પતાવવું છે, ટીમ વર્ક, આખા ટીમને ભેગા કરીને કામ કરવું અને લીડરશીપ, આ બધા માટે ખૂબ મોટી ઓપોર્ચ્યુનિટીઝ મળે છે. So hence, WealthCon is a journey from darkness and ignorance to light and knowledge. Thank you.
मेरा फैमिली टाइम, फैमिली लाइफ और प्रोफेशन कॉम्प्रोमाइज ना करते हुए मैं बहुत अच्छे से मेरी वेल्थकॉन जर्नी एंड वेल्थकॉन फैमिली एंजॉय कर रही हूँ.
तर मदर हे खरं तर अवघड काम आहे. मुलं झाल्यानंतर बॅकफुटवर गेलेल्या करिअरमुळे आलेले गिल्टी फिलिंग आणि आपली इंटलेक्च्युअल एनर्जी चॅनलाइज करण्यासाठी म्हणून सुरू केलेल्या शेअर मार्केट इन्व्हेस्टमेंट मॅनेज करण्यात
We are now going to start our second workshop of today's WealthCon. I request all delegates to be please in the hall. I request all delegates please in the hall. We are going to start second session of WealthCon.
The path to financial independence. Jai Hind.
सर्वांनी हॉलमध्ये येऊन बसावे हे विनंती. आपण आजचे सेकंड वर्कशॉप वेल्थकॉन चालू करणार आहोत थोड्याच वेळात. कृपया सर्वांनी आतमध्ये येऊन हॉलमध्ये बसावे ही विनंती. We are going to start now our second session workshop on WealthCon. शनस्य हा कनस्य विद्याम अर्थच साधयते. शनत्यागे कुतो विद्या कनत्यागे कुतो धनम. Knowledge should be gained through minutes to minutes effort. Money should be earned by coin by coin. How you get knowledge if you are wasting time? How can you accumulate wealth after wasting source? So after knowledge, we are going to shift toward the wealth. I request all WealthCon team to be present in front. I handing this stage to WealthCon team, Dr. Aparna Jagtap Madam. Dr. Aparna Jagtap Madam, please.
Good evening. I welcome all of you on behalf of WealthCon for this insightful and hope so would be useful seminar, that is basic investor course in financial education. Just now we played the video and in that we had seen the WealthCon tree. Well, we over here who are going to speak are proud to be small twigs of this WealthCon tree. And today we would like to put sincere efforts to touch the basics of this subject called is financial education. See, nearly our 1/4 or 25% of our life revolves around earning money. We go to schools and colleges to learn skills. Why? Primary aim is to earn the money. Rest all is secondary. During adulthood, more than half time of waking hours are spent to earn the money. It's quite significant part that of our life is gone to earn money. So question arises, do we have understanding of money, how it works, how to manage it, so as to get at some point of our life the financial freedom? I'm not saying at about 70 years when we have our broken teeth and our legs are shaking, quite earlier. So here comes the role of financial knowledge. WealthCon is a community of more than 20,000 plus doctors, and motto of WealthCon is to lit the light of financial awareness among doctors by the doctors. It was started in 2017 by Dr. Ramnath Gute, radiologist from Mumbai. I would like to introduce him by a small video. He's our mentor, guru, and founder of WealthCon. Of course, he would like to share some few words with you. Please.
सातारामध्ये जमलेल्या सगळ्या डॉक्टर मंडळींना नमस्कार. At onset, I would like to thank IMA Satara and all organizers. I thank to speakers who are prepared to spread the financial awareness, and I thank everyone who are watching and listening this talk. So when we speak about finance, it is something, it's a neglected subject, it is a boring subject. And when we started WealthCon 2017, it was something disguised topic, or we can say it's not so good appreciated. And one more thing I would like to appreciate more for the IMA Satara branch, because during those days, finance was not taken by any mainstream association or bigger association like IMA. But this is an encouraging step that our medical association are ready to take the topic as a finance. And I always say to my colleague that after a few years, we don't have to give talk. All our association will do themselves. So today's topic is probably basic finance. And if you are watching first time or listening WealthCon topic first time, so I would like to give a brief introduction. Rest of the topic will be taken by the speaker. At the beginning, when you are starting a financial journey, you have to clear some myths which you are holding about money and finance. So number one myth about finance and money is not important. That is biggest myth. Not myth, it is blatant lie. Money is important for to buy the things which you need. Okay, so yes, it may not be important, but it, you need health, you need good education, you need good house to stay, and all these things are important. To buy these things, you need money. So whoever says money is not important, they actually don't have it. So this is like sour grape syndrome. Second myth is money does not bring happiness. I always argue that happiness and money are two independent variables. You cannot correlate. Okay. So happiness is a totally different entity and money can totally different entity. One thing is certain. Whether presence of money brings happiness or not, that is a different question. Absence of money can certainly bring unhappiness, and there is no dispute. Third myth is finance is difficult and I don't know it. Mere ko nahi aata, and it is complicated. This is a myth. See, whenever we learning subject, we start from scratch. If I ask you about a specification of your car, you know what is the ground clearance, what is torque, what is the topper speed, and all specification. Did you know before buying car? Absolutely no. If I ask you the specification of mobile, you will tell how many GBs, MBs, and all specification. You learned it. And to buy a car of, let's say, 5 lakhs, 10 lakhs, 20 lakhs, you do research for at least 1 or 2 months. You visit various shops, trials, you ask 10 different people, you search online, Google. And you invest 50, 60 lakhs, crores investment without understanding anything, and you just sign on the form by the agents because you think that is difficult. I'll tell you, if you are spending 2 months to buy a car of 10, 20 lakhs, it is much easier to buy the shares of the companies which makes the car. Okay, so I will tell that buying share is much easier than the buying shoes on Amazon. Or it's much easier. So, and as you are attending WealthCon, you are automatically learn the mutual funds and shares. Okay, so after me, you will convince that now I want to start journey. Then where to start? That is the question. And today's session will give you impetus to start it. What I'll tell here that what not to do. Okay, because what not to do is extremely important than what to do. What not to do in stock market is number one, not to lose money. Okay, remember, पैसा नहीं आया तो चलेगा, लेकिन जाना नहीं चाहिए, because it is your hard-earned money. You cannot lose it. So you have to learn how not to lose. We have studied different format and we did all trial errors. After experience, we found that we do not know the reason of stock market success or investment success, but we know the reason of failures and losses. For example, in our medicine, 200 years ago, it was people were focusing on how to prolong the life, and they were finding the solution in scripture, the different theories, gods, and all this different modalities. Their aim was to prolong the life, but eventually nobody could find out what are the elixir of life. 200 years ago, modern medicine developed and approach was changed. We do not know the causes of long life, but we know causes of death. And modern medicine, we started focusing on the causes of death. And we try to prevent the causes of, we started treating the diseases, different syndromes and abnormalities. As of now, modern medicine may not be sure that what causes the long life, but we certainly know what causes the death. And we try to do, and every day you are doing the same thing. But result is life is prolonged, and now people are living 70, 80, even 90 years old age. But when India got independence, life expectancy was between 40 to 45. Now it is 65 years, because modern medicine focus on what causes death and prevent it. Exactly in stock market, you focus what causes the losses and prevent it. So we developed 4 or 5 causes. One is tips trading. Tips trading means someone tells you that buy these shares, whether on TV Pandit or social media or even friends, they give tip, you buy. That is number one cause. The reason, when you buy stocks on tip, you don't have conviction to hold. If it goes 20, 30, 40% down, you book the losses. So your own research is extremely important for holding the position. Second is intraday. Intraday trading is purely gambling. Okay, if you open the YouTube or Google, you will see thousands of people promoting intraday trading, but it is purely gambling. The reason, you have to close the position on same day. If you are not in position in profit, you have to close in losses. That is nothing but the gambling. So never do intraday trading. And for the doctor as a person, intraday is absolutely contraindicated. Okay, this is not relative contraindicated, absolute contraindicated. The reason, you have to focus on OPD patients and OT. You cannot trade while patients are sitting outside. You cannot operate when trades is live going on and you are opening the abdomen. You are working on the lives of patient. It is too risky. Not for you, your money will lose, that's okay. But what about the people who you are treating? So this is absolutely contraindicated. We strongly denounce intraday trading at WealthCon. We hear words, they are not supposed to join WealthCon. Third is penny stock. By and large, beginner people join stock market and start buying stocks of small value, like 20 rupees, 30 rupees, and they think they can buy huge quantity. They are cheap stock, but you have to understand that cheap, that is for reason. They are really cheap. They are, it's like a junk stock. Never invest in the junk stock, which are very small companies. These are manipulated by anyone and you will lose money. Fourth is stop loss trading. When you join, automatically you will be starting getting calls from different cities, Indore, Bangalore, Ahmedabad, Delhi, to invest this, and they will provide you target and stop loss. The stop loss is again form of gambling. You don't have to learn. So whenever you come across the word stop loss anywhere, you just have to run. Okay. So if you avoid these things, TIPS, it's an acronym for tips, intraday, penny stock, and stop loss. This is about investing in the stocks. Then two more points are there. One is never mix investment with the insurance. All insurance come invest plan are useless. Why useless? Their return is less than 6%. Your inflation is 7-8%. So you are losing money. Insurance plans are sold by smart people to the ignorant people. Now, whether you agree or not, it is easy to say deny, okay, this is all nonsense. But once you sit down and do calculation, you will understand, you'll accept the mistake and you will improve it. People who takes things on ego, they don't improve. You have to accept the mistake. You have to accept that I bought policies under the influence of ignorance, but now I am aware and I will get rid of. I will never buy the ignorance policy. In fact, we label the name as ignorance policy because it is bought by only ignorant people. And next is cash generation. Now, this is biggest point of discussion. We usually don't discuss it. But eventually, if you create a lot of cash, you cannot create asset in the white, means stocks or bonds, mutual funds, because where all money is documented. So undocumented, unaccounted money usually goes to real estate, etc. And if you sit and think carefully, even if you buy 20 crore property, you cannot eat it unless you sell it. You cannot enjoy the money. So ultimately, you are working money to enjoy it. And if your children are settled abroad, that land or property is as good as not useful. I'm not saying that don't buy real estate. In fact, we say gold, real estate, equity, debt, you invest in all four assets. And I'm sure every one of you are already loaded with the real estate. So your real estate quota is completed. Now focus into the equity and debt part. Okay. So these are the few basic principles, and all speakers will discuss little more detail and start financial awareness and journey yourself. Just remember that you cannot outsource two things. One is finance, another I cannot speak on public. Okay. So all the best. Thank you very much. Namaskar.
He's truly a very enthusiastic person and a passionate teacher. Once he starts speaking, he goes on speaking. Thank you, sir, for all your efforts and teaching. So without wasting much time, let's begin our journey towards finance. Our first speaker is Dr. Sudhir Kadam. Dr. Sudhir Kadam is practicing gynecologist in Civil Hospital Satara and is investing for last 10 years. He's an active member of WealthCon and working as a senior guide in TMP course. He's also the district admin of WealthCon team Satara. He has completed BIC TMP courses of WealthCon and also completed the 60 days challenge by Zerodha in all segments like currency, commodity, and equity. He's going to speak on introduction to personal finance. I invite him on the dais and request him to please proceed with your talk. Dr. Sudhir Kadam, sir.
Thank you, IMA Satara office bearers, for giving me opportunity to talk for finance. I am talking basic thing about the financial education or awareness. WealthCon is a darkness to light and ignorance to knowledge. It is the theme of WealthCon India. It started by the Dr. Ramnath Gute, and the community spread for 50,000 plus doctors across the India. And all the doctors are having great communication in between. Romance and finance are never to be outsourced. It cannot be delegated to others. You have to do it for yourself. About money, you can hate it, you can love it, but you can't ignore it. So financial education awareness is must. There should be balance between body, mind, and bank. That is physical health of our mental health as well as bank balance. Some myths about the money are: money is not important, rich people are bad, share market is gambling, finance is difficult, don't speak of about money in front of children. We have to remove all these things from our brain. Why doctors can be best investor? as doctors create value for them as well as society, bright student and hardworking, 6% of elite tax-paying group, best in learning new skills, good at decision makings, open-minded to change, quick adaptability, stable mind as per as other most of the people. But some are the lagging behind in financial literacy. This is because doctors are busy in medical practice. We mostly rely on agents and other persons or relatives for managing our finances. No learning opportunity till WealthCon started in 2017. No dedicated groups for doctor regarding finance. Why greedy? Chase your dreams. Let money chase you. As as Warren Buffett quotes, never depend on a single income. Make investment to create the second source of income. We all know that. Professionally, better quality of work and patient care, work towards well-being of the medical associations and other our colleagues. Personally, we can relieve the tension of building our network, time to pursue our own aim and passion as fitness, sports, spirituality, can give family time, quality of life should increase and educate others. At this financial education or awareness program, we can understand the importance of financial education, know the other avenues of investment and wealth creation, be able to select mutual fund themselves, be able to select some good stocks themselves, understand the difference between life insurance and other plans or ignorance policy, understand the impact of direct plan and on return and regular plans, know the key financial instrument for the saving under ATC. Don't work for money, let money work for you. As per Warren Buffett, the best investment you can make is investment in yourself. The more you learn, the more you earn. So start learning from onwards. 95% of club in India have only 20% of wealth, while 5% club, rich club, maintains the 80% of the wealth from India, and difference between them is the financial education. Now let's find out to educate ourselves. So some questions to ask are how much you are earning, how much you are spending, and how much you are investing. Investment should be as earning, spending, investment, taxation, protection as insurance and loan. As per Parkinson law, no matter how much money you are earned, they tend to spend more, entire amount of earning and save a little. Spending consists of some POPs and PON. We should focus on products of need. Products of need are required for living utility and convenience, living expenses and routine car, while products of prestige are not required for the survival and only for prestige and style sake, such as jewelry, luxury car, hi-fi phone, hi-fi watches. We should ignore products of prestige and minimum the buying of the product of prestige. We have to reverse the process of investment. That is, invest first, then spend while earning. Learn what is not an investment. Fixed deposit or FDs are not an investment. Ignorance policies or plans are not our investment because this does not beat the inflation. According to rational thinking, any decision based on calculation is correct. If decision is based on some logical thinking, then it also somewhat correct. But decision made on emotions or herd behavior are irrational. So see some calculations. If you invest in bank FD, a bank FD gives you interest about 7%. Most of us are in 30 30% slab rate of income tax. So post-tax return is 4.9. In India, inflation is almost 6 to 8%. So deducting the inflation, you are only getting -1 returns. That if you invest 100 rupees in a bank, you will get 98.9 rupees after a year. That is, so we have to invest in such products that can beat the inflation. Most of the know that LIC and FD doesn't give much returns. Still, we are using FDs and LIC policies for the investment purpose. This is because we are not knowing these good stocks and fear of unknown market territory. As per this chart, the equity market is having exponential growth compared to gold, silver, and other commodities. What is investment? Investment is a buying appreciating assets. Anything which you pays for you is asset, while anything which takes from you away money is liability. Reduce your liability and increase your assets. True assets are easy to sell, no emotional involvement. Examples such are cash, mutual funds, shares, land plot, commercial building, gold coins, SGB or paper gold. Pseudo assets are difficult to sell and have emotional involvements such as house, car, furniture, gadgets, jewelry. So financial products for wealth creation is topmost is equity mutual funds and equity stocks. For wealth protection, PPF, NPS or EPS. And wealth destruction products are ignorance policies or FDs. Gold jewelry is not an investment, it is an expense, but we have to do some expenses while in living house. Insurance is an expense. Don't waste any time to study expenses and never mix insurance and investment. They both should be kept aside. Must have insurances are term insurance, health and professional indemnity, car insurance and travel insurance. Dr. Jagtap madam will cover the insurance topic in detail. For ignorance policy or any other plan opted by any bank, LIC, HDFC, ICICI, anything will give return up to only 4 to 6%. That does not beat inflation. Insurance company also invest in stock market and make huge returns and gives a very less to us. So the final truth is buy term insurance. Sum assured is 20 times, age up to 70 years, premium payment till the end of policy, and buy policies from LIC, SBI, HDFC. Tax saving products are ELSS, PPF, NPS, home loan deduction, and Mediclaim. Dr. Jagtap madam will cover the tax saving part. Learn about the investment. Our finance is our responsibility. Don't outsource the finance. Be self-reliant. Finance is not a rocket science. It is a 7th grade subject, and even children can also start learning about the finance. Knowledge is available on everywhere, Google. We have to be receptive to become self-reliant. Why equity? Equity is to beat inflation, create value for portfolio. Indian economy is growing, huge potential on long run. India's GDP is increasing day by day. India is now passing the UK and will may pass in next 10 years up to US also. Why should we invest, fight inflation, compound interesting, and our hard-earned money, we should not lose it. When to plan? As early as possible. Today, if not started already. Time is the greatest compounder. Start early. Now, time is money. Power of compounding. Albert Einstein once said that compound interest is the 8th wonder of the world. He who understands it earns it, he who doesn't and pays it. For asset diversification, where to invest, gold 10%, real estate 40%, equity 40%, debt funds 10%. For inflation beating, these four are most important, and equity is 15% year on year. Real estate is advantages, it can give you rental income as well as capital appreciation. Disadvantage is low liquidity and requires huge capital. While advantage of equity is diversified portfolio, high liquidity, long-term returns are good and requires minimum capital. You can start with 500 rupees to 2000 rupees per month also. Two problems with stock investment are time required, I am busy, or knowledge is required. Knowledge is available at WealthCon also. Types of investors are passive investor. Passive investor have limited sources and can track market 6 monthly and invest in mutual fund, ETF, and active investor who can track the market once monthly or once 15 days can buy in SIP mode and deep buying. Seasoned traders or can well-trained disciplined traders and can increase the percentage of gaining. Tips trader should not be done. Disadvantage for equities is choosing the stocks and high risk of volatility or market condition. Mutual funds. There are two types of mutual funds, direct as well as regular mutual funds, and large cap, mid cap, small cap. SIP can be automated. Mutual fund part will be taken care by Dr. Bankar sir in detail. First one is there are two types of mutual fund, regular mutual funds and direct mutual funds. Regular mutual fund have 2% fund management charges, but that comes at approximately 20% of our profit share, and that is huge on year basis. Here we can see that if regular return is 14%, for someone invested 50,000 per month for next 30 years, that is invested value will be 8 crore and final value will get 22.7 crore. While direct person who investing in direct mutual funds, only 1% difference on returns, but still there is almost 5 crores difference on final value. So discard the regular mutual funds or mutual fund investment through agents and start direct. There are many platforms where you can invest direct mutual fund. ETF or exchange traded funds are the most newly thing which we can invest in for diversification. We can invest in Nifty Biz. It started in the 2001. Nifty Biz for Nifty Biz, first 50 companies are taken. Fund holds the all stocks of Nifty index fund in the same way, and 1 unit is roughly of 1 by 100 of Nifty index. Other Nifty ETFs are junior Biz, that is next 50 to 100 companies, liquid Biz and IT Biz, pharma Biz. They can also diversify. ETF are the best. It is having the less expense ratio. Diversification in ETF, it provides exposure to basket of stocks representing various sectors, good stocks in first 50 companies of India. Convenience of ETF, highly liquid and can easily buy and sell. Low cost ETF, as it will be having very low expense ratio. Liquidity is very good. We can select good stocks by MPTDS stocks. Dr. Bhute sir will cover the topic for selecting good stocks. Take home message is know yourself, know your limitation. A big no to ignorance policy and agents. Don't give appointment to any agents or any person giving the plans. Plans नाव ऐकलं की पळून जायचं, येऊ नको रे बाबा. Insurance is not an investment. Invest in equity, invest in mutual funds directly. Wealth creation products are shares, mutual funds, real estate. Wealth protection is PPF. Wealth destruction is long-term FD, Ponzi scheme, LMM schemes, and ignorance policy. Don't work for money, let money work for you. Welcome to the financial journey. Thank you. We will meet again.
Thank you, Sudhir sir. You have very beautifully explained the need of personal financial education for all the doctors. I'm sure everyone is convinced and will soon start his education journey in the finances. Now we'll have a deep dive in the field of finance. We have Dr. Shivaji Sonane, who's our next speaker. He'll be speaking on how to invest and where to invest, how to diversify your assets. His topic is asset diversification. Dr. Shivaji Sonavne is a practicing obstetrician and gynecologist in Satara since last 15 years. He is also an active member of WealthCon since 2019. He has completed basic investor course and TMP course. May I request Dr. Shivaji to take the dais.
Thank you. At the outset, I'd like to thank IMA Satara for providing me this opportunity and WealthCon India. The topic that is given to me is asset diversification. So special mention of Dr. Sudhir Kadam, who has given an excellent talk, and he has covered most of the personal finance. Many of my slides will be a repetition of what he has covered, but I think important points need to be hammered. So it will be worthwhile to repeat them. I begin with the first slide, that is the best investment you can make is an investment in yourself. The more you learn, the more you learn. This is by Warren Buffett, the legendary investor. Now about asset diversification, it's don't put all your eggs in one basket. So whenever we speak of investments, we think it's about equity, it's about shares, mutual funds, but that is only one asset class. If we were to put all our eggs in one basket, and for some reason there is a problem, we will be in a soup. So we have to learn what are the various asset classes, what are the benefits and risks of each one of them. So that's how you balance risk. What is asset allocation? You have to allocate these investments among different types of assets. So what are the different types of assets? Generally, broadly, there are 4 asset classes. First one is gold, second is real estate, third is equity in the form of either mutual funds or direct shares. Fourth is debt or fixed income. There is a newer asset class that is cryptocurrency, but we won't go into much details because that is a recent and sometimes it is called a bubble asset. So for a average person between the ages of 30 to 50, the allocation that is recommended between these 4 asset classes, gold, real estate, equity, and debt, is 10%, 40%, 40%, and 10%. So how much each one should invest in each asset class? It's not like a one size fits all approach. It is individualized to everybody. What are the various factors that are depends on the personality of the patient, the financial goals, the risk tolerance. A young investor will be interested in a maximum growth over the long term, so he can go for a riskier asset which gives a higher rate of return. Whereas somebody who is pre or post retirement, he is more interested in protecting the wealth that he has worked so hard, long and hard to accumulate. So he is likely to go for a slightly less return but a safer asset. So let's look at the returns on investment in the last 10 years for the various asset classes. First one, you can see equities, they are given 17.6% returns. Gold has given 9.8% returns. Real estate on an average has given 11.6% returns. And bank fixed deposit has given 4% returns. So except for bank fixed deposits, most of them are giving good returns. So what are the other factors to consider? factors is the time horizon. For a young person, he has got lot of earning years ahead of him, so he can go in for a riskier asset which is volatile in the short term, but in the long term he's most likely to get good returns. Then is the risk tolerance. There are some people who don't want any risk on their money or their capital, so for them equity is a slightly riskier asset class. Debt is good for them, debt and gold. Liquidity issues. There are some assets which can be immediately sold. Shares, if you buy today, tomorrow you can sell. But for real estate, it's not like that. You have to find a customer, then sell. There's so many things, litigation. There are tax concerns. Some assets are favorably looked upon by tax authorities. For example, equities are given favorable treatment in tax. So taxation is less on whatever returns we get. Whereas debt has higher taxation. There are some legal constraints. Real estate most of the time is there. There are some legal problems with land issues, unique circumstances. So which investment options can give you inflation beating returns? So this is the same bar diagram that we had earlier, that we can see green line is the inflation line. So except bank fixed deposit, most of them are giving inflation beating returns, but the highest is with direct equities and equity mutual funds. So again, we'll go to the fixed deposit. That is the most favored asset among historically, but it can't beat inflation. There is a fixed return of interest that is 6 to 8%. There is no compounding. So if we were to invest 10,000 rupees in a fixed deposit, after 1 year at 7% rate of interest, we will get 10,700 rupees. But on that, there is a 10% tax on those 700 rupees. So 70 rupees goes to tax. So what remains is 10,630 rupees. So on that, again, we have to calculate inflation 6 to 8%. So that comes to around 637 rupees. So at the very end, what we get is 9,993 rupees for 10,000 rupees invested. That is it is a negative return after 1 year. But we generally tend to ignore inflation. Mahagaila पण we don't give that much importance, and then we lose on the long term. Now to the next asset class, that is gold. Historically, it has given a return rate of about 8%. But what are the risks? There is a risk of theft. If we have to buy ornaments, there are making charges involved. So it is not an ideal investment. Ideally, we should limit it for ornaments. There are some benefits also. If we invest in paper gold, it's very easy to invest. There is no theft issue. Gold investments will give high dividends over the long term. Over the longer term, it will definitely beat FDs. You can convert paper gold into jewelry whenever you want, jewelry and ornaments. And also, if we even have physical gold, you can mortgage that gold and take a gold loan. So these are certain advantages of having gold. So what are the drawbacks? So price of gold is associated with several macroeconomic factors. There is no tax advantage. You won't get a tax rebate for investing in gold. The cost of storing and maintaining gold is high. There is no regular income in the form of dividends or rent. There is no transparency in case of buying and selling gold. It's less. I won't say no, but there is less transparency. The third asset class is real estate. So real estate, there are some benefits. Let's look at the key benefits. First one is comparatively low volatility. So it's very rare that you buy real estate at some price and then you have to sell it at a lower price. So that is a very big advantage of real estate as an asset class. A gradual increase in market price will lend stability to your investment. You can avail of house loans easily by mortgaging the property. And if the property is rented out, you can earn regular income. So these are the key benefits. What are the drawbacks? So it requires a large initial capital to invest in property. You cannot invest in property with some minimum 1,000 rupees or something like that. The initial capital required is more. The transaction costs are high due to stamp duty registration. The cost of maintaining the property in the form of property taxes, light bills, water bills, etc. That makes the cost high. Also, there is a problem of liquidity. You won't buy a ready buyer when you want to sell, and litigations with real estate is well known. What are the benefits? Key benefits? It diversifies the investment portfolio and reduces the risk. Like everything in equity, instead of that, we can have 40% in equity, 40% in real estate. Now we go to the next asset class, that is equity. It is relatively easy to liquidate the stocks and funds. We have the potential to earn high returns. Also, if you go by the mutual fund route, you can start with a minimum amount of rupees 500. The money that we invest in mutual funds is handled by professional fund managers, and the post-tax returns are efficient. As we all know, there is only 10% tax on long-term gains on equity. So that is very good for somebody like doctors who are in the 30% tax level. So what are the drawbacks? The drawbacks is there is a high risk that is associated with short-term investments. There is high volatility in the short-term investment, that probably if we are to invest some amount today and then the market crashes in the next month by 40%, your money goes down immediately by 40%. So in the short term, there is a risk. And some people find it difficult to choose stocks. But is it actually true? Is whether picking stocks is difficult? So if you look at some of the top in holdings of 3 mutual funds, see Axis, Canara, and Mira Asset, we can see that these top large blue chip large cap stocks such as HDFC Bank, Bajaj Finance, Infi, all these which are on the screen, they form the bulk of the portfolio. So we can directly purchase these stocks at least directly in our portfolio. We don't need to go through the mutual fund route and pay them the fund management charges. This is again a repeat slide. Compound interest is the 8th wonder of the world. He who understands it earns it. He who doesn't pays it. So there is a formula for compound interest. The A is the final amount that we'll get. That is equal to the principal that we invest multiplied by 1 plus R is the interest rate divided by number of times the interest is compounded per year and raised to the time in years. To put it simply, if we are to invest 10,000 rupees at 6%, at the end of year 1, you get 10,600. But now you reinvest the interest. At the end of year 2, you get 11,236 rupees. So now this is compounding. So initially we won't see much difference, but as the years pass, this goes on increasing. So to put it in a graphical form, we can see the blue line is the simple interest and the yellow line is the compound interest. In the initial years, both of them are running together. But after about 3-4 years, the compound interest starts giving exponential returns. So another same slide, similar method. The principal is $1,000 that has been invested at both in the simple interest and compound interest. The blue zone is the simple interest. So as we can see in the initial 3-4 years, there is not much difference between the two. But after the 4th year, the compound interest has picked up and the simple interest has gone slightly flat. So at the end of 20 years, $1,000 invested has gone to $3,000 in simple interest, but the compounding has taken it to 7,000, more than $7,000. So we can look at it in another way. There are 4 investors. One has started investing at the age of 25, second has started at the age of 35, third has started at the age of 45, and fourth has started at the age of 55. The returns they have got is the same. The amount that they have invested is the same. But just because somebody started early, his end corpus is, as the difference is for the one who started at age 55, he has got only $94,911,000, and one who has started at the age of 25, he has $7,22,485 So it's nearly a 7-fold rise. So what the take home message is that the one who starts early gets the benefit of the compound interest because he's stayed in the market for so long, and so his money has compounded and grown very nicely. Now something about systematic investment plan, the SIPs that we do, everybody does nowadays. Everybody has an SIP. So let's just go through it. If you have a monthly SIP of 5,000, the NAV of the fund is 10 rupees in the first month. So the units that we get is 500 units. The second month, the market slightly goes down. So NAV has gone down. So it's 9 rupees now, NAV. But the units that we get, they are 55 units we got more. It's 555. So in a falling market, the units purchased are more. In the third month, the market has gone up. Now the NAV is 11. Now we have got only 454 units. So a falling market is a boon for the SIP investor. What we tend to do is when the market falls, we tend to withhold our investments. We tend to say now the market is going down, we should stop our investments. And when the market goes up, I'll again do. But that exactly is the thing that you should not do. Because when the market goes down, you tend to get more units. And if your aim is more than 7 years, 10 years, definitely your wealth creation is going to happen only when the market is down. For a long-term investor, the market being down is the best thing that can happen. Now this is a table in which we can see the comparison of asset classes. Three we have compared: equity, gold, and real estate. The first point is entry barrier. For equity, only a small amount is required to start. In gold, an appreciable amount is required, and in the real estate, requires a high amount to start. Regular savings is possible with equity, not possible with gold and real estate. Risk is high in equity, medium in both gold and real estate. Returns are potentially high in equity, medium to high in both gold and real estate. Liquidity is high in equity, medium to low in gold, and low in real estate. Regular income, yes, if the stocks and funds are dividend paying in equity. Real estate also you get regular income if you rent out, but gold you don't get regular income. Long-term capital appreciation is there in all the three. Transparency is high in equity, low in gold, and medium in real estate. Tax advantages are there in equity, no in gold, and there are a few tax advantages in real estate. Cost of maintenance is negligible in equity. Gold cost of maintenance is high, and real estate cost of maintenance is high. Professional management you get in equity, you don't get in gold and real estate. Transaction costs are low in both equity and gold, high in real estate. Ease of selling is is good in equity. There is no ease of selling in gold and real estate. And part selling of the asset is possible in equity, also possible in gold, but difficult in real estate. Take home message: physical gold is only for jewelry. Invest in equity and real estate to beat inflation. Mutual fund, exchange traded funds, direct plan, growth option. That is important, not regular plan. Debt investments for capital protection. Somebody who doesn't want to risk, he can go in for debt investments. Price is what you pay, value is what you get. Thank you.
Thank you, Dr. Sonavle. You have made the concept of asset diversification quite crystal clear. Hope our audience find it useful and would help them to plan their finances accordingly. One thing I want to add, that in the equity market, he said the risk is high. Of course, the risk is high because market goes up and down and we don't have control on it. But eventually, as the market is booming, India's, so for a long term, it's definitely going to go up. And here it is in WealthCon, we don't recommend that he has already told that don't put all the eggs in one basket. So there is a percentage for equity investment also. So whatever your income is there, we have to divide it like 50% goes for the expenses, 10%, 40% goes for the expenses, 10% goes for the tax, and remaining 50% you invest. In that, only 20% is recommended for the equity, in which this ELSS, shares, and mutual funds comes. And remaining 30% are for your EMIs, your other check payments, and save in some debt, or you can side by side in the trading to build a portfolio or build a money so that you can buy real estate when the money gathers at you. So in this way, we have to divide. Suppose if the market crashes, everything doesn't crash, only the equity segment, you can wait for it to come up. Okay. So people just blame the equity. It goes down, सगळं झालं, खाली गेलं, सगळं बुडलं माझं, असं नाही. तुम्ही थांबायला पाहिजे त्यासाठी. You have to give time for equity to work. I request our next speaker, Dr. Deepak Bankar, to please come on the dais and deliver his lecture. He's going to speak on mutual funds and how to select them. Dr. Deepak Bankar is practicing radiologist since last 15 years. He's also an active member of WealthCon and completed his BIC, that is Basic Investor Course, School Trade, and TMP course of WealthCon. I request him and welcome him. Sir, please continue.
Thank you, ma'am. Thank you, Team SATCON, for giving me this opportunity to talk in this conference regarding a very important topic, which usually we tend to neglect, that is mutual funds and how to select it yourself. Usually, we tend to give it to an agent and who selects it for us, and we usually tend to neglect this part. So, what is mutual fund? What is the concept of mutual fund? How it works? Mutual fund, it's an organization or managed by fund managers. These are professional players who are experienced and knowledgeable. We give money to them. We invest our money in them. They invest our money for on behalf of us in the share market or in different assets. They generate money out of it and they give a particular percent back to us. That is how the mutual fund it works. What are the types of mutual funds? They are regular mutual funds and direct mutual funds. What is regular mutual fund? Regular mutual fund is usually the one which involves agent in between. It has a high expense ratio. Direct is the one where we invest directly. We avoid the expense ratio, which is around 1%. And as Dr. Sudhir said, it compounds to almost 10% eventually. So we should go for direct mutual funds. Then what are the don'ts in mutual fund investments? These are like, we should avoid new fund offers. We should usually invest in different sectors. We should avoid investing in a single sector. Then we should go for some mutual funds like dividend giving mutual funds. Then there are different types of mutual fund based on the category of mutual funds, like large cap mutual funds, small cap, medium cap, flexi cap, and then we have liquid funds, equity funds, debt funds. So how to select mutual funds out of all these funds? We should ideally go for equity, wherein we should select for large cap, mid cap, multi cap, ELSS, and flexi cap. In debt fund, we should go for liquid funds. We should avoid fancy funds or solution oriented funds like children fund or retirement fund, something like that. And the last is ETFs, that is exchange traded funds. So we should go for these types of funds. So now in next 20 minutes, I'm sure you all will be going to be expert in how to select mutual fund for yourself. WealthCon has designed a criteria called KERSA criteria, wherein by using all the points given in KERSA criteria, we can select 5 or 10 mutual funds which are good for you. The C in KERSA criteria stands for category of the fund, age of the fund, that is since how long the fund is in the market. Then A is asset under management. So what is the capital, market capitalization of that particular fund? Usually we recommend a fund which is more than 5 years in the market. Age should be more than 5 years. The asset under management should be more than 1,000 crores. Then the R is return. We try to take short-term return as well as long-term return. We should go for 1 year return, 3 year return, 5 year return, up to 10 years return. We should look for that. Then is the expense ratio. The expense ratio should be minimal, as minimal as possible. It cannot be zero, but try to get it as minimal as possible. Then last is Sortino. Sortino and Alpha, I'll talk a bit more about it later on. Just keep it in mind that Sortino and Alpha both should be higher the better. Now going to the categories, we should select either equity based mutual funds or debt funds. In equity, we should go for large cap. What is large cap? These are the funds, fund managers, fund houses who invest in large cap companies. So large cap companies are usually the one who have got market capitalization of more than 10,000 crores. Then mid cap are between 5,000 crore to 10,000 crore, and small cap are between 1,000 crore to 5,000 crores. So we should invest in large cap, mid cap, small cap. Flexi cap is the one which invests in any of these. They are not like they will invest only in large cap or mid cap. And last is ELSS. ELSS is equity linked saving scheme. That is a tax saving scheme. It is an option to PPF. Usually we invest our 1.5 lakhs in PPF every year. So this is a good alternative to PPF ELSS. You can, it's a mutual fund which gives tax benefit. Then in case of debt funds, you should usually invest in liquid funds. This is how we give a prescription of mutual funds. If you want to invest in 10 to 12 different mutual funds, go for 2 ELSS, 2 in large cap, 2 in mid cap, 2 in small cap, 2 in liquid, and 2 in arbitrage. But it's not a compulsory that you should invest in 12 different mutual funds. Now, how to select it online? You have to log into valueresearchonline.com. It's a website. You can create your own username, password. It's a free website. So you can, once you log in, go to the base of the page. There is a fund selector option. Go to fund selector. In fund selector, you go to category. In categories, you have different options like equity, debt, hybrid. Go to equity, debt, and select from there only large cap, mid cap, small cap, flexi cap, and liquid funds. So this is how we select all the categories. Once the categories are selected, you can see in the chart. Pointer. Okay, this is how we select the category of the fund. Once the categories are funds selected, we update the list. It's there in the options. Now we select 2 more options, that is open-ended and direct plans. What is open-ended and close-ended? Open-ended are the funds which you can exit at any time. There is no time limit, or there is no, in case of close-ended, we have a like restriction of 3 years or 5 years. We cannot exit the plan before 3 years, before the recommended time. So we should opt for open-ended plans, and we should opt for direct. Like as I said, we should avoid regular plans. So select the category, go to open-ended, select the direct plans, and then update your list. Once this list is updated, you can see in the category, the next to the category is launch year. So in launch year, you can select the stock which is launched at least 5 years back. So you should avoid selecting stocks which are like in the markets in last 5 years. So you can see that in the launch category. Then last column is net asset. That gives the details of the asset under management of that particular stock house. So you should select the one which has got asset under management more than 1,000 crores. We have covered category, then age and asset. Now we go to return. In the return tab, you have got 2 options. One is long-term return and the other is short-term return. There you can see in the chart, you have got in long-term return, you can see 3 years return, 5 years return, 10 years return. And in short-term returns, you can see 1 week return, 1 month return, 6 month return, up to 1 month return. So whichever is giving more returns, you should select that particular mutual fund. Next is expense ratio. As I said, expense ratio should be minimum, because that is the amount which fund house is going to charge us for all the processings. Okay, so the least is the expense ratio, more will be our profit percentage margin. Now Sortino ratio. What is Sortino ratio? Sortino ratio is useful in evaluating portfolio's return in case of a bad situation. So if the situation in the market is bad, so we should know in that particular situation which fund manager will give you the best return. So that is called Sortino ratio. This ratio should always be higher. Now what is alpha ratio? Alpha ratio compares that particular stock with a benchmark stock in that particular sector. So as compared to the benchmark stock, your stock should give a higher ratio, higher percentage. So that is called alpha. Alpha ratio should also be always high. So like if a fund house has an alpha ratio of 1, So it gives like it performs benchmark by 1%. So in risk stats, you should select the high Sortino ratio and high alpha ratio. So once all this is done, you have selected your interested categories of the stocks. Then you selected the one which has got good asset under management, which is there in the long time in the market. Then it is given long term as well as short term returns are good. Its expense ratio is less. It has got very high Sortino and alpha ratio. So this is how you shortlist your 5 or 10 stocks. Then what you do next? You start SIP in the stocks. You can start weekly SIP or monthly SIP. Usually we go for a monthly SIP. Then I don't recommend selecting multiple stocks. Don't go on wasting your money in selecting. Don't select single stock, because if that select single mutual fund, because if that particular mutual fund performs poorly, all your money will go invest. So select 5 to 10 mutual funds, diversify according to the sectors, so that even if one sector goes down, the other sector will go up and your money will be balanced. Okay. This is how we usually diversify our mutual fund portfolio. ELSS, as I said, you can invest your 1.5 lakhs per year in ELSS for the tax saving. Then large cap, the shares will be taken care by Dr. Bhute sir. He'll tell you how to select shares using MPTDS criteria. Then go for large cap shares by selecting MPTDS criteria. Then go for mid cap mutual funds, usually 2, and small cap mutual fund, usually 2. This is how you should diversify your passive investor portfolio. What are the platforms which you can use to buy your own mutual funds? So these are the like mutual fund utility, Kuvera, Zerodha. Zerodha Kite is for stocks and Zerodha Coin is for mutual fund, and AMC portals of various banks. They also give the opportunity to buy through their portal. How to select your SIP amount, or how to select the duration for your SIP. Can you minimize? Go to mutualfundsahihai.com. There they have given SIP calculator. Okay, so you can log in there, click on the SIP calculator. So if someone is investing 5,000 rupees every month in a particular fund, he is expecting returns of around, say, let's be realistic, 12% per year. And if he is investing for next 10 years, then you can see here his total investment for 10 years is 12 lakhs, and what he will be getting at the rate of 12% is around 50 lakhs. So for 12 lakhs at the end of 10 years with the rate of interest of 12%, 5,000 rupees per month can give you 50 lakhs at the end of 10 years. So here the important factor is duration. So how long you stay in the market. If I reduce the duration to 5 years, you can see your invested amount is 3 lakhs and what you are getting is 4 lakhs. So it's good to stay in the market for a long time. Second way is goal SIP calculator. So like if your goal is to have 1 crore rupees after 10 years, if you want to have that amount in your mutual fund, so this is your goal amount. 1 crore. you want to stay in the investment for next 10 years and you expect mutual fund to give you 12% return. So this is how it should be. Like you should invest around 43,000 per month in mutual fund for next 10 years, and at the rate of 12 years your amount invested will be 52 lakhs and what you will get is 1 crore. So this is how you can calculate the amount which you can invest based on your capacity right now or whatever amount you wish to earn in the future. So depending on both these things, you can decide how much to invest and how long to invest. So what is the take home message after this? You should always invest in direct plan. It should be a growth plan. Use CARESA criteria to decide which mutual fund to select. Then you should not invest in more than 10 to 12 funds. Go by SIP mode. There is a wonderful automation given in all the, I use Zerodha and there is an automation in that. If you decide a date and amount of your SIP every month, then the money gets automatically deducted and the SIP, it gets automatically earned in your account. So make it automatic, regular and consistent. You should stop running behind fancy and hot name funds. Okay, thank you and happy investing.
Thank you, Dr. Bankar sir. Dr. Ram sir has given us this mantra of CARESA and the next topics MPTDS. And sir, you have elaborated it very nicely. जेव्हा मी पहिल्यांदा BIC अटेंड केलं तेव्हा हे सगळं नवीन होतं आणि हे सगळं माझ्याही डोक्यावरून गेलं. म्हणजे जे फर्स्ट टाइम ऐकतात ह्या सगळ्या गोष्टी. बट ॲज टाइम गोज अँड जसं आपण डीप याच्यात जाऊ तसं अगदी 7वीतला मुलगा देखील ह्या क्रायटेरियाने गुड शेअर्स अँड गुड फंड्स सिलेक्ट करू शकतो. बी अश्युअर दॅट. Now I request Dr. Nilesh Bhute, our next speaker on the dais. Dr. Nilesh Bhute is a consultant anesthesiologist practicing in Satara since last 15 years and past secretary of Indian Society of Anesthesiologists in 2018. He is also a proud WealthConian. He has completed his basic and TMP courses of WealthCon. He is going to speak on topic how to select good shares by MPTDS criteria. I invite him on the dais and request him to carry out with your lecture.
Hello.
Today I am going to talk about stocks, how to purchase stocks through this MPTDS criteria. Just start with some question answers. How many of you invest in stocks other than associated with WealthCon?
Stocks. How you select stocks?
Actually, I'm also new in this stock market. I studied stock market on YouTube. So I started investing during COVID time. And my portfolio before COVID was 50,000 rupees. During COVID time, it was somewhere around 4,50,000. And after finishing COVID, I sold out whole thing for 7 lakhs. Okay. After that, I invested only 2 lakhs and still it is 2 lakh and something. So I don't know what is going on. But during COVID time, I purchased stocks. Those are, I was knowing that going to increase. So I purchased that and I sold out because I was knowing I could not able to monitor after that. So I sold out whole my this one portfolio. So that's what I learned about the stocks.
It's good thing you are learning on its own.
Just I want to interfere. Dr. Sanjay Pawar, today I welcome him. He is our observer for today's our session, and he is a physician running his own hospital in the Karad. I wish him that after seeing this lecture and observing this lecture, he will have some knowledge and he will get some message from here so that he can do the better investment for him. Thank you, sir.
It's good thing you are
Thank you.
studying the stock and then purchasing. Okay. Vikas,
So,
are you?
I am YouTube learner still in the
Okay.
stock market. So I have not taken any course or anybody's support for the stock market.
Okay. It's a great thing. Vikas, sir, how you purchase?
आम्ही असं तुमच्यासारखे मी
We
डॉक्टर
require
विकास
we
पटेल काही
require a
विकास आहे.
sincere, genuine answer.
हा असेच असेच तुमच्यासारखे तज्ञ आमचे मित्र आहेत बरेचसे. त्यांच्याबरोबर आमची उठबस असते सकाळ संध्याकाळ इकडे तिकडं. तर त्यांच्या बोलण्यात नाही येतो एखादा स्टॉक, मग आम्ही त्यात थोडेफार इन्व्हेस्ट करतो आणि गोत्यात येतो.
So you are dependent on any other agent or your friend?
No, friend like you only.
Okay.
म्हणजे मतलब
Yeah, your friends.
हा.
Okay. Yes,
त्यांना
relatives.
असतील आपले त्यातले
Okay.
शेअर मधले तज्ञ आपल्यातलेच कोण कोण.
Suppose you want to buy a sari or you want to buy a shirt. So what things you will do?
Search myself.
Yes. Yourself, what things you will choose?
Quality,
Yes.
cost.
Yes. So you will see material of the product, quality of the product, which company. So this is MPDDS criteria, nothing else. Okay. You are using daily products like Vaseline or Pond's famous powder. So do you know which company it has? Yes, Hindustan Lever. So you should observe your daily products you are routinely using in day routine. Okay. So to select the company, we have our Welcon discovered this MPDDS criteria. Okay. So this MPDDS criteria is for diagnosis and selection of fundamentally good stocks. So that is quality and material of your shirt or sari. Okay. So what is the need of these MPDDS stocks? There are 4,000 companies registered on NSE. So you have to select only 20 companies. So to select these 20 companies, we have this MPDDS criteria. So what is MPDDS criteria? This M is market capitalization, P is price, T is tax, D is dividend, and S is sales or revenue. So how to apply it, we will see. This market capitalization is more than 10,000 crore. So what is market capitalization? That is price into number of shares. So again, one question. In IT sector, which is the biggest company? Anyone knows? Yes? Other than Welcon members, please. समजतंय कसं तुम्हाला की ते लार्जर कंपनी. So market capitalization. So price of the share into number of shares. The multiplication of this is bigger in case of TCS compared to Infosys. So TCS is bigger company. Okay. Next is price chart of the stock in last 10 years. Should be uptrend. T is tax paid by the company, D is dividend paid by the company, and S is sales clocked by the company. It should be increasing on ascending over last 10 years. So where to look for these parameters? That is screener.in. If possible, you can see now only how to select a stock. You open your Google, go to screener.in, open your account. It is a free website. So you create your username and password. Right now, you can also start searching the different stocks with this MPTS criteria. So I have just logged in this. I entered my username and password and entered the screener. So this is home screen. So go to tools. Then create a stock screen. Can you see this? Create a stock screen. Okay. So here is a one box where create a search query. So write down here, first criteria, market capitalization. So write down market capitalization. Yes, it should be more than 10,000. Okay. No need to write crores because see here all values are in crores. Okay. So run this query. So here it is. There are on 335 companies. So out of 4,000, only 335 companies we are filtered. So you have to select only 20 companies from these 335 companies. Okay. So we'll see one by one. So click on Nestle India. So first criteria is market capitalization more than 10,000 crores. See, Nestle India fulfills this criteria because its market capitalization is more than 10,000 crore. Okay. Next criteria is price. So go downwards. Here is a price chart. So you have to select. Already they have selected 1 year. You have to select 10 years or maximum. Can you see this? This is more than 10 years chart. So this price is going from 2006 to 2022. Here is uptrend of the price. So price is gradually increasing. Okay. So Nestle India fulfills this price criteria. Next criteria is tax. So again, you go to cash flow. Here in cash flow, cash from operating activity. Can you see this direct taxes? Pointer, pointer. Okay. Can you see this direct taxes? Okay. So see this, there is minus sign in this because company paid taxes to NSE India. So minus sign is there. So see the taxes from 2011 to 2022. So taxes are increasing. Here is 364 to it goes to 841. So here is tax also is uptrend. So Nestle India again fulfills this criteria, tax. Next is dividend. This financial activity, go in cash from financial activity. So we'll see dividend paid. Again, there is minus sign as company paid to the government, to the customer. So from 2011, it goes to 2025. So again, dividend is also increasing. It is uptrend. So this Nestle India again fulfills this dividend criteria. Last is sales or revenue. So go to profit and loss. First column is sales. First, then you have to compare from 2011 to 2022. Again, sales are increasing. So again, Nestle fulfills the sales criteria. So Nestle completely fulfills MPTDS criteria. So you can buy this MPTDS criteria. Okay. If you want to search any other company which is not fulfilling MPTDS criteria, Adani is the best example because now Adani is in very much in news. So we'll see. See, market capitalization criteria is fulfilled. See the price. This is not uptrend from 2006 to 22. Flat line is there. So Adani is not fulfilling the MPTDS criteria. So you should not enter in this stock. So like this, you have to select the stocks. Okay. PPTs. Same thing explained here. See, price of share steadily rising over last 10 years. See the price chart of Reliance, it is in uptrend. HDFC, it is in uptrends. Hindustan Lever, it is in uptrends. TCS, it is in uptrends. C for S Bank, it is not in uptrends. So it is MPTDS doubtful criteria. Direct taxes, this is dividend, just now I explained. In profit loss, it is sales. So after studying this, you have to categorize the stocks, that is MPTDS valid, MPTDS invalid, MPTDS doubtful, doubt about any component, any price, tax, dividend. Then MPTDS is having high specificity and low sensitivity. So apply this MPTDS criteria and select 20 to 30 best performing shares across various sectors and 2 stocks of each sector. Across various sectors means what? You have to select 2 from IT, 2 from finance, 2 from FMCG, 2 from real estate. So you select 10 sectors and 2 companies. So you can have 20 stocks. Then SIP and add-on dips. Dips means 10% fall from recent high. SIP means every broker has the facility to start SIP in stocks. For a particular date, your amount is deducted and that stock is purchased. So you can start SIP on particular date. And dip buying is what? Dip means 10% from fall from recent highs. Suppose price is 22,000, 2200, and it falls to 2,000. So 10% fall is recent fall is there. So you can add the stocks with price of 2,000. Okay. Your investment should be minimum for 7 years. Review portfolio once in a year or SOS if there are any red flag sign with. 3D approach for investing in shares. You should have diversification, just now explained. SIP and DIP and duration 7-year minimum. Thank you very much. Thank you, Ramnath Gute sir and IMS Satara.
Hello, Nilesh. Can you explain what is dip?
Dip means 10% fall from recent high. Suppose share price increases from 1,000 to 1,000 to 2,000, suppose, and again it goes to 1,800. Then that is 10% dip. So you can add the stock with 1,800 price.
Will you please explain, because here are all newcomers. So going to these sites, looking for MPTDS, can you have some idea whether they can take the shares regularly on specific date or as like SIP, not with the deep? Always they cannot see the calculation. What was the share price yesterday or 15 days back, and now what is the price today? So how can they recollect? So can you explain any one method so that they can purchase the shares of? You have selected the specific share. Yes, you have explained very rightly. But for example, Nestle. So when to buy, and he wants to buy regularly. So what is that method?
Suppose you don't want to study the share every month. You select through MPTDS criteria. Suppose you have selected Nestle one, and start investing in Nestle one through SIP. You select a date which should be last week of the month. So it is observed that last week shows there is decrease in price. So you select a 25, 26 of every month. Your money will be deducted every 26th of month and share will be added to your portfolio.
So this is a passive investment.
Yes.
Although it is in the shares also.
Yes.
If as we put our collection of our practice and put it in the bank, and we doesn't see it. This is usually happening with our practitioners, and then we know that after the year end, we saw this investment have become more, and now question arises what we have to do. So this is the passive investment, and but it is in the equity. So specific, not a specific rate, but definitely it is correcting or beating the inflation, and you are getting the more money. Or little bit of observation is always necessary while investing, but it is always beating the inflation. And although it is not that means passive, although it is a passive investment, it is always helpful than the FD and all the other things.
Okay. Remember one thing, you should visit or you should see the stock once in a year at least.
Nilesh, would you like to enlighten about exit criteria? You have mentioned one about that investment should be of 7 years. Any other criteria do you think while purchasing stock, exit point of view?
Exit point of view, for passive investor, you forget about exit. You invest for 7 years. After 7 years, you exit. See for price and time.
So ask about the goals. That means exit goals.
Okay. Your aim should be you should beat the FD rates. Once you beat the FD rates, you can exit within 7 years also.
It is usually said that before you enter, you should have an exit plan. So what is that? Exit plan is either time-based or goal-based. So if your target is you should have sufficient money after 7 years, then wait 7 years, don't exit. So that is exit goal. And second is goal-based. That is you want to generate a corpus of say 1 lakh or 10 lakhs. Once it is generated, you exit from that particular stock. So it is like either goal-based or time-based.
Third criteria you can add is price-based. I think because when you select that stock at particular price, you should select the percentage also. That this much of percent amount, by looking at the graph, you can select the percentage also, and at that percentage I am going to leave. This you should decide. So this is one, I think this is one of the criteria. Yes.
If you want to want money after 2-3 years, don't invest in stocks directly.
MPTDS क्रायटेरिया तुम्ही सांगितलं त्याप्रमाणे जर बघायला गेलं तर तो सेफ गेम खेळला जाईल.
बरोबर.
म्हणजे याच्यात हे काही जे 50 स्टॉक आहेत ते आपण सिलेक्ट केल्याप्रमाणे त्याची जी ग्रोथ दिसते 10 वर्षातली किंवा एकदम स्लो स्टेडी ग्रोथ आहे. त्याच्यात काय असं फार मोठी मला वाटते काय
अवघड काय नाही.
अवघड पण काही नाही आणि फार काय मोठं अचीव्ह होईल असं पण काही नाही. म्हणजे 10% 15% जास्तीत जास्त तुमचं त्यात इन्फ्लेशन मिळत जाणार.
ओके.
पण त्याच्या व्यतिरिक्त जरा थोडस तुम्ही असं काहीतरी सांगा. थोडक्यात एखादा शेअर घ्यायचा आहे तो पहिला चांगल्याच कंपनीचा, परंतु चांगल्या कंपनीचा आपण जसं म्हणतो की एक क्रायटेरिया आहे की 52 वीक हाय आणि लो.
ओके.
तर तसं जर बघायला गेलं तर ह्या सगळ्या कंपन्या आहेत ज्या त्यांचा काही 52 वीक हाय अँड लो फार काय असं नसतोय लो मधला. पण अशी काही परिस्थिती ती मार्केटमध्ये काही काही कंपन्यांचं की या क्रायटेरिया फुलफिल करतील असं पण नाही काय. पण त्यांचा 52 वीक मधला लो जर एखाद्या टाइमला अचीव्ह होत असेल तर तेव्हा तो घ्यावा का नाही.
जर काय एमपीटीडीएस क्रायटेरिया फुलफिल होत नसेल तर तो 52 वीक्स लो असेल तरी तो शेअर घेऊ नये.
Sir, we are medical practitioners and we want peace of mind. So
करूच नका ना.
नाही असं नाहीये.
तुम्हाला जर अभ्यास
We
करायचा
want to
चांगला
diversify our portfolio and invest in proper different assets, and so these criteria have been
सेफच आहे ना. मग हे सेफ आहे, अगदी सेफ आहे. एमपीडीएस अगदी सेफ आहे.
Sir,
पण त्यात
your-
तुम्हाला थोडीशी रिस्क घ्यायची.
Yes.
काय करायचं तर
What is your risk taking capacity? How much fall you can bear? First, you have to know yourself. If the market crashes, if the price of that particular stock falls down, I can wait, I can bear it, I can wait for the price of that share to come up. Then you play this game, sir.
This is a very good question actually, which Dr. Patil sir has asked. So I would like to say, some stocks, good stocks are at a 52-week low. So we are tempted to buy it because we have seen that stock at 3,000. Now it is at 1,500. We feel 1 year back it was at 3,000. Now it's a good bargain. But actually, stock market doesn't work like that. If it is at a 52-week low, there is a reason for that. Market is anticipating that probably the company is not doing good. It's not having good earnings. The profitability is less. The profit margins are degrowing. So ideal strategy is you should buy stocks which are going at 52-week highs. Stocks which are making fresh 52-week highs. So that is what we should target. So there we can make money rather than stock which are at 52-week. No. So stocks are making highs because there is a reason. Market is not a gamble. Market participants, they may be foreign institutional investors, domestic institutions. They buy stocks because they feel, they anticipate growth in the next. So if today Mahindra and Mahindra is making a fresh 52-week high, they're anticipating that the cars, the whatever personal vehicles Mahindra and Mahindra have created now are going to sell like hotcakes. The profitability of the company is going to increase, and therefore the marketing is giving that premium. So it's safer to buy stocks at 52-week high rather than at 52-week low. Now I'll give you an example. The share of Reliance in 2016 was at 800 rupees. For the last 10 years, it was at 800 rupees. It fluctuated between 800 and 1000. In 2016, it started rising. It became 1600. There was a stock split. Again, it came to 1000. And now again, it's gone up. So once it started growing, the market gives premium. If you had invested at 1200, 1300 at the fresh 52-week high, you would have made even 2 times the money. So that's my opinion. We should buy stocks at 52-week highs because this is the most common mistake that is made by us, buying stocks at 52-week lows.
Second thing I want to add, this investment is for passive investor. Okay. If you want to buy at 52, then you should become active investor. What is active investor? हा स्टॉक 52 weeks low ला का गेलाय हे कळण्यासाठी you should study fundamental analysis of that company. So that is not included here. Here we are dealing with only passive investor. तुम्ही सकाळी 10 पासून संध्याकाळी 8 पर्यंत तुमची प्रॅक्टिस करा, ह्याच्यात तुम्ही इन्व्हेस्ट करा आणि more than FD you earn the interest. That is the fact.
Year on year growth maintained by Warren Buffett, the largest investor of the world, is 23 to 24%. So we should aim for 80% more greed comes with more risk. Market will take away clothes also. So should limit our greed. 15 to 18% year on year is good returns.
Can we have question answer session after the madam's lecture is the last one? After that we can have question answer session. Thank you so much Dr. Nilesh sir. मला वाटतं आता स्टॉक सिलेक्ट करणं खूपच सोपं केलंय निलेश सरांनी. साडी घेण्यासारखं झालं. स्टॉक कसा सिलेक्ट करायचा. ऍक्च्युली वेल्थकॉनने स्टॉक मार्केट इन्व्हेस्टमेंट 2 पार्ट मध्ये डिवाइड केलंय. पॅसिव्ह इन्व्हेस्टमेंट आणि ऍक्टिव्ह ट्रेडर्स. ऍक्टिव्हला आपण ट्रेडर्स म्हणतो. तर आपण आज फक्त पॅसिव्ह इन्व्हेस्टमेंट कव्हर करतोय, ज्याच्यामध्ये स्टॉक शेअर्स कसे सिलेक्ट करायचे, म्युच्युअल फंड कसं सिलेक्ट करायचं आणि त्याच्यामध्ये पॅसिव्ह इन्व्हेस्टमेंट कशी करायची, म्हणजे मंथली SIP सुरू करायची आणि विसरून जायचं. ठीक आहे. आपल्याला तेवढा वेळ नसतो की रोजच्या रोज स्टॉक मार्केटचे फ्लक्च्युएशन्स बघायला किंवा तेवढं स्ट्रेस घ्यायला. ऑलरेडी आपल्याकडे बराच स्ट्रेस बाहेर असतो आपल्या प्रोफेशन मध्ये, त्यामुळे हा एक्स्ट्रा स्ट्रेस नको असतो आपल्याला. सो वी आर फोकसिंग बेसिकली ऑन पॅसिव्ह इन्व्हेस्टमेंट. Our next speaker is Dr. Aparna. She is a practicing obstetrician and gynecologist in Satara Sanchit Hospital since last 13 years. She is also active member of WealthCon. She has completed basic investor course, cool trading course, PFG and TMP course. That is almost all the courses by the WealthCon. And she will be talking about the taxations. आता पैसे तर कमवले shares मधून, आता taxationचं काय. तर about the taxation, insurance and good loan and bad loan. So may I welcome Dr. Aparna Jagtap on the dais, please.
Thank you for the kind introduction. I first of all thanks organizers and IMA for giving me this opportunity. Now we have seen up till now various aspects of personal finance, why equity, investments in shares, mutual funds. I would like to speak on taxation, insurance, and loans, which is also equally important in our financial management plannings. So, first to go for taxation, we know that death and taxes are certain. मरणार तर आहोतच आपण कधीतरी आणि टॅक्सेस पण आपण पे करतोच. Whatever income we have, we invest in assets and we pay the income tax. नाहीतर काय करतो? We generate the cash and we spend on what? Travel, hotels, महागड्या गाड्या, महागडे कपडे, सोनं, दागिनं, असं सगळं. Okay. Don't we have to pay the tax on it? Of course, there is GST. So WealthCon recommends not to evade taxes, no cash generation. Most of us believe that objective of tax planning is to minimize the taxes. We buy real estate, life insurance, collaborate with life insurance with investments, and collaborate with our CA to show limited taxes. However, the right goal of tax planning to pay appropriate tax and maximize the post-tax income, ज्याला आपण white money म्हणतो. So let's go into the basics of tax. So taxes are of two types, direct tax and indirect tax. Government आपल्याकडून घेतच पैसे. तुम्ही नाही भरलं तर आम्ही कुठून ना कुठून तरी घेणारच. So direct taxes are income tax, security transaction tax, which is on the gains of mutual funds, shares, etc. Corporate tax, businessmen's. The indirect taxes are GST, excise tax on imports, custom tax on imports. Other terminologies like current financial. So now for today, the current financial year is 1st April 2022 to 31st March 23, in which period we pay the advance tax as per the taxation slabs, dates are declared, and the assessment year is the next year where we pay, calculate and pay our taxes. So for today, the next year is the assessment year, that is 1st April 2023 to 31st March 2024, where we have to pay the taxes as per the government declares the date. So now about something from where the income comes, heading. So most of our salaried, so the income from salary, house income, that is if we rental house income, then profession and business income for us, like we are doctors, so doctor profession. Then capital gain, this is the profit which we get after selling the capital assets, and other incomes like interest from bank deposits, dividends, interest, gifts, lottery and betting. Something let's clear about exemptions and deductions. Exemptions mostly for the salaried people. So it's like house rent allowance they get, then leave travel allowance, food coupons or vouchers, company leased cars, standard deduction, uniform allowance, leave encashment. These all are exempted from our gross income. Then the deductions like public provident fund, equity linked savings scheme, ELSS, employee provident fund, life insurance premium, principal and interest component of home loan, children tuition fees, health insurance premiums, NPS, that is National Pension Scheme, and saving account interest. Government has allotted certain amount for deductions if we invest in all these things. Now, in 2023 budget recently, the new regime has been declared. Something related to that, in the new regime, there are no deduction. All the deductions and exemptions are in the old regime. And for us, once once the new regime is selected, we cannot revert back to the old regime. So we have to first calculate, think over it, and then select the regime. Till now we were paying by the old regime. So whether to go for the new regime or not, we have to decide on all these factors. The only benefit in the new regime is the standard deduction, that is 50,000, which is also available in the old regime. So these are the tax slabs under the new and old regime. In the old regime, the first slab, that is 0 to 2.5, that is 0% tax. 2.5 to 5 lakh, that is 5%. 5 lakh to 10 lakh of the income, profit, that is 20%. 10 lakh and above is 30%. This is after all exemptions and deductions, the amount. According to the new tax regime, here, apart from standard deduction, no other exemptions and deductions are considered. So in this, 0 to 3 lakh is 0%, 3 lakh to 6 lakh is 5%, 6 lakh to 9 lakh is 10%, and 9 lakh to 12 lakh is 15%, 12 lakh to 15 lakh 20%, 15 lakh and above 30%. So 6 slabs have been made. So the question is whether we should select old or new regime. So there is no any straightforward answer, because every person is different. His income, his or her income is different. What, in which instruments that person invest, like in tax saving products, yes or no, whether he has any exemptions, yes or no, and on all these, it depends which one to select. So if we approach systematically, we can figure it out which is best regime for us. I'm not going to tell, because everyone should know how we should calculate. So the steps are: first, calculate all exemptions, look at the deductions, combine these two, and minus from your salary or the income to see your taxable income, and then put in both the regime and see which is which saves more tax, which fits you, and then you can go for it. Mostly it is said that when your income is less, say about 10 lakhs, 15 lakhs, taxable income, then the old regime is still better. New regime is better because you save tax if you have no deductions. But if you have already invested in various tax saving products, then the old regime is more beneficial. As the income increases more than 30 lakh, 50 lakh, 60 lakhs, then the new regime could help. Now about the capital gain tax. Now we have various investments, we have various assets. As the years go by and by, we sell them. Then we have at the higher price, then we have those profit. So the capital gain is any profit or gain which occurs after the sale of capital assets. Capital gain tax, as per the income tax law, the capital gain tax, the capital gain comes under the category of income, and we have to pay it according to our tax slab. The capital assets are wealth, or whatever we have in the form of money or other assets that are owned by a person. These are physical, like gold, animal, machinery, house, building, shops, land. Financial, like equity, shares, mutual funds, debt products like bonds, securities, debentures, deposits, and intangible like trademarks, brands, licenses, patents. The entry point, and if during the exit we have profit, so we have to pay taxes on it according to our tax slab. Now, how this capital gain asset gain tax is calculated? So it depends upon the duration you have been invested in that, and the class of it, asset class. So in the equity component, like shares of listed companies, equity mutual funds, balanced mutual funds, if you are in investment for less than 1 year and you sell it out, then the short-term capital gain is taxed. So the tax is 15%. If the duration is long, that is more than 1 year, then, and if that long-term capital gain exceeds 1 lakh rupees cumulative, all the capital assets gain, then we have to pay 10% taxes on it. For the gold asset, if it is a physical gold, coin, jewelry, gold ETFs, gold mutual funds, if you have kept for less than 3 years, you have sold earlier to the 3 years, then whatever gain you are getting, you have to pay as per your income tax slab rate. If you have kept for more than 3 years, then 20% of the gain with indexation, which I will cover in the next slide. For the debt products like debt mutual funds, bonds, government securities, and treasury bills, if you have been in the investment for less than 3 years, again the profit which you are getting, you have to pay the tax according to your income tax slab. And if you are in the investment for more than 3 years and then you sell, then you will get the 20% with indexation. Some other immovable properties like house, land, and building, if you sell them within 2 years, then whatever profit you get, you have to pay according to the income tax slab rate. And if you have you own it for more than 2 years and then you sell it and you get the profit, you have to pay 20% with indexation. Is there any way to save the capital gain tax? First is expenses. You can show various expenses you have that has been incurred while taking or while selling. So that is repair, maintenances, legal expenses, registration fees, etc. That you can show, you can minus, and then the profit, then you can pay the tax on the profit. Other is the indexation. See, the buying cost increases due to inflation. Hence, the benefit, this benefit is given to the in the tax calculation to the seller, because as the days pass, the cost is also increasing, inflation rate is also increasing. So this is indexation. Suppose in 2010 you have bought the gold of 10 lakhs. Then in 2020 you sold at 30 lakhs. So the profit is 20 lakhs. So are you going to pay the tax on 20 lakhs according to the slab rate? No. Here comes the indexation. So formula is whatever is the buying cost multiplied by the cost inflation index of present, that is 2020, upon the cost inflation index of 2010. It is on, we easily get on Google if we search all the years cost inflation index. So here in this case, the indexation is the 10 lakhs was the buying cost. Indexation of 2020 cost inflation index was to 301, and for 10 was 167. So we get the 18 lakhs. So the selling cost is 30. We have to minus this 18 lakhs, and so the amount remained is 12 lakhs. So we have to pay the tax on this 12 lakh, not, and that to 20% if more than 3 years. Sorry, 1 year. So we get a benefit of 8 lakhs. This is the calculations of indexation. Now there's a section called as section 44 ADA. So this is a special provision by the tax department for small professionals whose gross receipts are less than 50 lakhs. Whatever gross receipts you are having from your profession, if it is less than 50 lakh and your net income is considered to be more than or equal to 50% of gross receipts. This is the eligibility criteria who can avail this or file its income tax under this section. So if you show your gross income more than 50% or equal to 50% and you avail the 44 ADA section, there is no need to keep the books of accounts or no audit is required. But if you are showing less than 50% of gross your profit, then you have to keep the book record and you have to even do the audit as per advised. So this is हे फायदा आहे 44 ADA ह्या sectionचा. Another section is of section 54. हे थोडंसं रेसिडेन्शियल प्रॉपर्टी बद्दल आहे, जेव्हा आपण एक घेतो मग विकतो मग दुसरी घेतो. So the tax department has also given some benefits or exemptions in the tax. Like if the section 54, the individual or Hindu undivided family, they can avail this, they can file under this section. So if your original asset sold is the residential property compulsory, the holding period should be, it should be at least more than 2 years. Then you have the long-term capital gain on it. The new asset which you should buy should be also the residential property, and it should be purchased 1 year before the selling or 2 years after the selling, within 2 years. Or if you are going to construct a new house using that money, then 3 years after. So here, whatever by selling the first house, we got the capital gain, that is exempted if we fit in all these criteria. And the limit is up to 2 crores. In Mumbai, Vagara, the houses are 2, 7 crores, and they invest directly from one house. They keep on changing the all celebrities' houses. Okay, so in this way, we can use this exemption. The another section is of 54F, where which an individual or HUF can avail. Here, any capital asset, mutual funds, astil, shares, astil, anything, other than residential property, if we are holding it for 2 years, more than 2 years, obviously, and then we sell, we get the long-term capital gain. And if we buy the paishatun, if we buy the residential property, same clauses that within 1 year before or within 2 years, or under construction within 3 years, then this all the capital gain is exempted from, it is exempted, so we don't have to pay the tax on it. The another section is of 54EC, where also the asset is residential property. If we hold it for 2 years and then we sell, we get the long-term capital gain. And of whole money, if we take the government-backed infrastructure bonds, like NH, national, road departments astat, NHAI, वगैरह, then that LTCG maximum up to 50 lakhs is exempted. But in WealthCon, we do not recommend to take these bonds because the returns are very less and we have to keep it for more than 5 years, a long term. So there are many other instruments where we can invest. So, but if anyone is taking, he can apply for this exemption. Now something related to tax saving products. खूप आपल्या असते bombarding, ATC, ATCCD वगैरे वगैरे वगैरे. So in WealthCon we recommend these 4-5 deduction or tax saving products. Now in under ATC the limit is 1.5 lakhs. In this the WealthCon recommends 2, that is equity linked savings scheme. The person who is younger, he can take a bit risk, he can wait for some periods, so that we have seen that in ELSS, the returns are nearly more than 8 to 10. Some ELSS even give for 12 to 14% returns for the long term. So we can invest in this. Also the PPF, it is very well-known product where the entry is exempted, even the amount which we get, profit which we get, that is exempted. All the long-term capital gain is exempted, so that EEE. So we can invest in PPF. It is a cumulative under ATC, whatever products comes, it is a cumulative that is up to 1.5 lakhs we can invest. आपण त्याच्यापेक्षा जास्त इन्व्हेस्ट करू शकतो, पण जर आपल्याकडे बेटर प्रोडक्ट्स असतील आणि आपल्याला माहिती असेल तर just keep for up to 1.5 lakhs in these products, and rest all you can invest in other assets. But if you are towards the retirement phase, then the PPF is a better and safer instrument, and you can also claim for the ATC tax. ATCCD, only one thing is recommended, that is National Pension Savings Scheme. Up to 50,000 we can avail and we can claim for the tax deduction. Then in other things like home loan interest deduction up to 2 lakhs, even the principal as well as the interest we can show as a deduction. It comes under 24B. Then 80D, that is Mediclaim health insurance of self, spouse, you're going to, if you're going to pay, then dependent children, you can show under your taxation and claim for the deductions. Then ATD, that is mediclaim of your parents. If more than 60 years you are paying, and up to 50,000, you can claim it. The claim can be a bigger one, but you get a deduction only up to 50,000. Let's move on to insurance. All I've been telling, Ram sir has told, Dr. Sudhir Kadam has told, insurance is an expense, so don't waste time to study. So I'm also not going to waste your times telling much about this insurance. Some few points are there, just focus on it. And the very much important is never mix insurance and investment. आपल्याकडे खूप एजंट्स येतात, एवढे रिटर्न्स मिळते, तुम्ही ह्याच्यात इन्व्हेस्ट करा, तुमचं इन्शुरन्स पण होईल आणि तुमचं इन्व्हेस्टमेंट होईल, काही बघायला नको. जस्ट इन्व्हेस्ट दिस अमाऊंट 6 lakhs 5 lakhs, अँड तो टेन्शन आपल्या डोक्यावर राहते की फॉर एव्हरी इयर आय हॅव टू पे दिस मच अमाऊंट, नाही तर मला इन्शुरन्स मिळणार नाही, माझं काही झालं तर माझ्या मुलांचं, माझ्या स्पाऊसचं काय होईल. ओके, सो बट इट इज नॉट द फॅक्ट. SATCON recommend the insurances like life insurance and general insurance. In life insurance, only term life insurance, pure term insurance, no component of investment, no ignorance policies. जे कोण जे सांगतं की बाबा इन्व्हेस्टमेंट पण होईल तुमचं आणि तुम्हाला इन्शुरन्स पण मिळेल, डोंट गो फॉर इट, बिकॉज द कम्प्युटेड annual growth return, that is CAGR, what we are getting on these investments are very low. You can invest in other assets where you can get 10%, 15%. If you're doing FNO, you're getting more than 100% also. Depends upon your risk things. Even a normal PPF will give you 8%. So you have to think whether the PPF is safe or these ignorance policies are safe. So no thinking of it, just pure term life insurance. Who have already bought the insurances under these all investment come insurance, SATCON recommends that if you have to again re-evaluate yourself. What if I redeem the policy? What if I take the new policy according, like someone is saying you do these things, so you have to calculate it. If more than 10 years are left for your this insurance premiums, you have to think over it and re-evaluate, and then think of the taking new insurance policies. Those who are in the recent years of income earning, please go for pure term life insurance. Then general insurances are like health insurance, car insurance, professional indemnity, and travel. I've already told this. So points to ponder before taking the life insurance policy. Why to buy? Obviously, for giving financial protection in untimely, unfortunate demise of the earning member. Who should buy? An earning person who have dependents and liabilities. If both husband and wife are working, are earning, दोघांचाही insurance काढला जातो. Then no need for children's or those who are spouse who is dependent on him, who doesn't earn. It's an expense, so you have to limit your expenses. When to buy? As early, at young age, as the premium fixed is low, start early. Where to buy? You can buy offline as well as online. Offline from agent, but he should be young, because he should outlive you to help you while or your family to settle the claim. नाहीतर दुसऱ्या कोणाला शोधत बसायला लागतं, आपल्या आधीच तो जातो. Which to buy? Even online is better. We have to study the insurance, and even the discounts are given, but we have to study different companies, whether it fits in our norms, what premiums are there, what are their claim settlement ratio, what are their solvency ratio. If the claim, they are good, higher claim settlement ratio is there, of course you should select that. If their solvency rate is good, you have to you can select it. And claim rejection ratio is also there, that also you see it, and you can select any of it. Which any good and top company, चांगल्या company मध्ये select करा, which gives low premium, good solvency ratio, high claim settlement ratio, for example, HDFC Life, SBI, ICICI, ProLife, LIC, etc. How much cover? It's a personal choice. म्हणजे तुम्ही किती ह्याचं प्रीमियमचं इन्शुरन्स घेणार आहात, तुमच्या फॅमिलीला, तुमच्या फॅमिलीची लाईफस्टाईल काय आहे, त्यांचे मेजर आउटब्रेक्स काय आहेत, लाईक मॅरेज, चिल्ड्रन एज्युकेशन, एक्सेट्रा. You have to decide on that. Generally, it is recommended that 20 times annual income or at least 20 times the annual expenses plus liabilities, kai कर्ज घेतलं असेल वगैरे. According to that, you should have the cover. Sum insured cannot be increased later unless you opt for the life stage protection. म्हणजे एखाद्या स्टेजला मी सम इन्शुअर वाढवू शकतो असं त्या पॉलिसीमध्ये फॅसिलिटी असेल, then you can avail it. Now other points to remember: take plain term insurance without riders. Policy, keep it simple, very simple. Policy period up to 60 to 70 years. तुमचे मुलं सेटल झालेली असतात, so there is तुमचं गरज फार आता नाही. You have no liabilities, they are earning. त्यामुळे त्याच्यानंतर गरज नाही. Then some policies even give up to 90 years. काय गरज आहे ना, नंतर काही आपल्याला गरज नाही आणि एक्सपेन्स आहे, आपल्याला आपल्या खिशातून ते पैसे प्रीमियम्स द्यायचे असतात. सम गिव्ह ऑप्शन्स लाईक लिमिटेड पे, देन सिंगल पे. नो, ओनली रेग्युलर अॅन्युअल प्रीमियम. फिल फॉर्म yourself, रीड ऑल क्लॉजेस व्हेरी फाईनली. तुमच्या एजंटवर सोडू नका. सगळे बारीक सारीक गोष्टी बघा, काय देतंय ते पॉलिसी, काय नाही देत ते सगळं बघा. डिस्क्लोज एनी मेडिकल हिस्ट्री. आपण मेडिकल हिस्ट्री आपण डिस्क्लोज केली तर आपलं प्रीमियम वाढेल, आपण ते झाकून ठेवूया? नो, कारण त्याला पिरियड असतात आणि त्या दरम्यान नेमकं तुमचं काही मेडिकल आजार समोर आले, देन दे कॅन रिजेक्ट द पॉलिसी, द बेनिफिट. देन मॅरिड वुमन प्रोटेक्शन ऍक्ट registration. I'm going to speak later on this. Then if terminal illness waiver is there or disability waiver is there, then it is good, you can opt for it. Ask for medical test before buying. काही policies करत नाहीत, हा चालतंय आम्हाला, ओके, बट नो, यू आस्क. काही डिटेक्ट झालं तर त्यांचं प्रीमियम वाढू दे, हरकत नाही, पण नंतर कळण्यापेक्षा आधी कळालेलं बरं. डू नॉट फॉरगेट टू रिन्युअल, कीप ऑटो डेबिट. बऱ्याच वेळा आपल्याला विसरलं तर मग त्याची आपल्याला पेनल्टी भरायला लागते. सो MWP ऍक्ट, मॅरिड वुमन प्रॉपर्टी ऍक्ट, मस्ट नो अँड मस्ट डू थिंग. बऱ्याच जणांना मेनी आर इग्नोरंट, इवन वी वर इग्नोरंट फॉर इट. सो इट इज टू प्रोटेक्ट द फायनान्शियल फ्युचर ऑफ युअर वाईफ अँड चिल्ड्रन. आपण आपल्या मुलांसाठी, आपल्या बायकोसाठीच करत असतो, आपण नसताना त्यांचं सगळं सुरळीत व्हावं म्हणून. The policy amount goes to the nominee, whatever कोणाची नावं त्याच्यावर आहेत त्यांनाच जातात, बट इट इज नॉट इम्युन फॉर द क्लेम्स ऑफ क्रेडिटर्स. जर तुमचे मिस्टरांनी कर्ज काढलं असेल किंवा तुमचे चालू असतील किंवा अदर डिस्प्यूट असेल तुमच्या फॅमिलीजमध्ये, अदर लिगल हेअर्स ऑफ हजबंड, दे कॅन ऑल्सो क्लेम फॉर द पॉलिसी, वॉट एव्हर क्लेम यू गेट ऑर द बेनिफिट यू गेट आफ्टर डेथ ऑफ द अर्निंग पर्सन. How to register for this? Any married man in India can avail this. He can appoint the beneficiary as wife, children, or both. Only thing is, once fixed, even husband cannot change. Even if they get divorced, ती फक्त ती जी काय इन्शुरन्स आहे ते तुमच्या वाईफ आणि बायकोची प्रॉपर्टी आहे. डोंट थिंक ऑन इट मच. Must apply before buying or the issue of the policy. Once it is issued, एकदा तुम्ही घेतली, पॉलिसी इश्यू झाली, अँड देन यू गो फॉर इट. नाही मला MWP ऍक्टच्या अंडर रजिस्टर करायचे. नो, यू कॅन नॉट. खूप जणांना माहिती नसते, इवन एजंट्सला देखील ह्या गोष्टी माहिती नसतात, तर आपण हे माहिती असणं गरजेचं आहे. Now about health insurance, as other points I have discussed earlier, for the life insurance it also goes for the health insurance. The WealthCon recommend individual mediclaim policy for each family members. Upon family floaters घेतो, but what happens if one of the member get hospitalized and if all the मतलब जे काय क्लेम बेनिफिट आहे त्या मेंबरला मिळालं and the second member gets ill and hospitalized, we cannot claim for the other person. So it is better to keep it simple, and for individual person you can, even for children also, health insurance जसं ते मोठे होतील
तसं ते यूज करतील. इवन इफ दे रिलोकेट, म्हणजे तुमच्याकडे तुमच्या बरोबर राहत नसेल, दुसरीकडे राहत जाते, तर त्यांची पॉलिसी त्यांच्या बरोबर राहील. अँड वन मोर रेकमेंडेशन इज सुपर टॉपअप. जर तुमचं बिल मोर देन वॉट एव्हर बेस अमाउंट और सम एश्युअर्ड इज देअर, इफ दॅट इज ट्रिगर्ड, देन यू कॅन दिस अंडर दिस सुपर टॉपअप ते बिल देखील आपलं आपण क्लेम करू शकतो. It is preferred over top-up policy, because in top-up policy only once we can claim in the year, but in super top-up multiple times hospitalization झालं आणि तुमच्या बेस पॉलिसी पेक्षा जास्त बिल झालं तर तुम्ही you can claim for the super top-up. So the person who needs multiple hospitalization, they should definitely take this super top-up on your base health insurance policy. Another is critical illness insurance policy. दोन्हीतला डिफरन्स आहे की पहिल्याला हॉस्पिटलायझेशन लागतं आणि दुसऱ्याला इवन डायग्नोसिस ऑफ क्रिटिकल इलनेस इज ऑल्सो इनफ. दे लमसन अमाऊंट विच इज जी काही ठरवलेली असते व्हाईल टेकिंग द पॉलिसी, यू गेट दॅट होल ऑफ द lump sum amount. For example, if the patient is of kidney failure, stroke, major organ transplantation, cancer, paralysis, it is those who are above 40 should take this critical insurance illness insurance policy along with your health insurance policies. See that now we are doctors, so we should also talk about the professional indemnity insurance. See, we treat the patient and treatment outcomes are never assured, and some unfortunate human errors also cannot be eliminated, and this exposes doctors to the risk of claims from the patient. Today claims can pose a significant threat to the financial security. कोणी क्लेम केलं 1 करोड 2 करोड, आपल्याला जर ते compensation द्यावं लागलं तर it will obviously disturb your financial whatever security is there. So professional indemnity is very important. There are some inclusions and exclusions. Inclusion is negligence, then errors and omissions if during the treatment, then the defense cost, whatever cost we get for this, then applicable to medical staff. Exclusions are if deliberately you do criminal act of fraud, surgery performed under the influence of alcohol, cosmetic surgeries. In this also option is there, any one accident and any 1 year of insurance policy, the ratio is given like 1:1, 1:2. WellCon recommend 1:1 ratio, where whatever sum assured is there, that whole amount you will get when you claim under it. Options are under IMA, National Professional Protection Scheme, New India Assurance Company, and United India Insurance. Car insurance under Motor Accident Act, it is mandatory, so now we have to take it. Types are third party insurance, comprehensive car insurance, and standalone. In the third party, only the third party liabilities are covered. In comprehensive, both third party as well as the legal liabilities are also covered, and in standalone, only your own damage that is covered. Other third party insurance is not given. Now loan. So loan is nothing but modern slavery. This was the old age slavery, and now under credits we are in the modern slavery. So loan should be taken very wisely. We have to think over it. These are types of loans like good loan and bad loan. Good loans which increase, when you take the loan, it should increase the productivity, it should create the assets, it should save the tax. For example, our business loan, home loan, and education loan. The bad loans are non-productive, like consumer loans, car loans, personal loan, gadgets, credits. म्हणजे आधी काय म्हणतात त्याला, कर्ज काढून दिवाळी साजरी करू नये असं म्हणतात. So before taking loan, ask yourself, why do I need loan? Is it absolutely necessary? What is the cost of borrowing the money? Can I handle more debt? Can I afford monthly payments? These are small criteria which are good and where we should be aware of. So if your debt is less than 30% of pre-tax income, then it's good, okay. If it is between 31 to 36% of pre-tax income, okay, you can still take. If your loan is debt is 37 to 40% of pre-tax income, you have to get alert. And if the loan is more than 40% of the pre-tax income, beware, it's a danger. I don't know whether you can repay it. So While giving the loan, the bank or the creditor sees all this income tax return, your CIBIL score, and report what assets you have. So it can be used as a mortgage and income, your income. So this credit information bureau, it gives us your score. It ranges between 300 to 900. It measures the credit worthiness of individuals. Higher the score, higher the chance of approval. And for businesses, the civil rank is used. So decision to go into the debt alters the course and condition of your life. You no longer own it, your life. You are owned. This Dave Ramsey say. So the debt-free life is a peaceful life. So take home message. If you want to create assets, do not avoid tax, insurance, only life insurance, that is pure term insurance, and loan, aim to become debt free as soon as possible and avoid the bad loans. At the last, being a woman, I want to give a message to all of you, especially the ladies. The eve of Women's Day is coming near, and here I want to you to understand something earnestly.
Hello, everyone. Thank you so much for coming to help us conduct this experiment today.
We were of different ages. We were made to like stand in a line.
Now, I'm going to ask you a bunch of questions. If your answer is a yes, step forward. If it's a no, please step back. Here goes. Ready? Did you learn how to ride a bicycle before the age of 10? Did you learn music in school? Did you take any lessons in sports? And no, video games are not a sport, even if it has the word game in it. Did you learn how to iron your clothes while still in school? Take a step forward. If not, take a step back. If you can make tea or breakfast, not just for yourselves, please step forward. If not, take a step back.
In the beginning, I think the questions were more general. People were still going forward and backward. Questions like, it was funny to see like the cooking question. There were a lot of men who went ahead and there were women who were going behind.
Do you usually make all the household bill payments yourself? Do you know the circle rate in your area? Do you know the price of gold today? Do you know the exact breakup of your salary?
As the questions unfolded, the stark difference came out visibly.
Do you know the details of the financial documents you're asked to sign? Have you bought a vehicle in your own name without consulting anybody? Have you bought insurance policies unassisted? Do you watch or follow the budget?
Like you think you're doing okay, but then you're like, okay, these are kind of important things that I don't look at.
Do you manage your own finances and earnings unassisted? Do you know how to invest in mutual funds? Do you know the difference between a mutual fund and an SIP? Do you make the investments for your family members or your spouse? Do you file your own income tax return? Now, everyone who's in front, could you please turn around and look behind you? Initially, when you guys started moving, there wasn't such a big gap. My question is, when did this gap start to occur?
The minute the questions became about managing money, the gap between men and women became very clear in everything.
You know, women handling certain responsibilities regarding their own life, which were always passed on to someone else in the family or the men.
There was a slight unfairness I realized at that time. But at that point, it seemed normal. I was upset. I wanted to be at the front of the line. It's like, why don't I know this? Why am I not confident enough to say, yes, I am able to understand this?
It was quite an eye-opener for me because I always depended on the men of the family to take care of my investments and, plan my future.
I felt that obviously men are more into it
than women. So eventually, I did expect the gap to be there.
Over the years growing up, there were certain very traditionally masculine tropes that were assigned for him, and certain traditionally feminine tropes that were assigned for me.
For women, it's practically debarred to learn to know and to focus on money.
I wish I had known from the beginning of my childhood and like kind of thought about that I would be doing so much better.
Just actionable measures is what we want, really.
Thank you for watching. Whenever I see this video, my eyes get tear-filled. And I really thank my husband because he is the one who forced me to study the finances. Actually, I was not interested. I always used to say, "Tumi ahe ki, mala kashala." But today I'm happy and proud also. I even thank Dr. Ram sir for he has always answered in the groups, even the petty and silly questions and never did the gender bias. I thanks from all today's Satara WealthCon speakers to IMA Satara and the organizing team for giving us opportunity to speak in front of all of you. And I thank the audience for the patient listening. So let the journey begin. I also thank the audiovisual team. They have really contributed very nicely. So let's begin the journey towards the finance education hand in hand. We do not claim that we are expertise in this field, but this is the culture of WealthCon. Whatever knowledge we have, it is said to we are told to instill this knowledge among the fellow colleagues. कारण आपण नेहमी शिकत राहिलं पाहिजे कारण शिक्षण कधी वाया जात नाही. And this is from us to all of you. Thank you. Thank you very much.
Hello.
I call upon today's our MMC observer, Dr. Sanjay Pawar, to come up and to share some his thought about today's workshop and what he experienced about today. Please, Dr. Sanjay Pawar, sir, come forward.
Good evening, everybody. Today, I'm an observer. What is a MMC observer? And today at 1:30, I got called that you are observer. Yesterday, I saw the later from the MMC, but I was not knowing the conference is at the 2 o'clock. So I'm a little bit late. I'm very sorry for that. But still, when I was coming from Karad, just Dr. Jagtap shared link to me, and I opened the link and I saw the lectures. Those are on the finance. So I was a little bit confused. Then again, I rechecked it. What is it exactly? Medical conference or something else he has sent to me. And afterwards, I saw that SATCON. So I thought that is a medical conference only. And I'm really very much thankful to this IMA Satara keeping such a topics in medical conferences. कारण आपणाला माहित आहे की आपण बरेचसे कष्ट करतो, आपण पैसे कमवतो आणि ते पैसे कसे वाढवायचे हे आपणाला कोणी शिकवत नाही बिईंग अ डॉक्टर. कारण आपणाला फक्त पैसे कमवायचे माहित असतात, पण ते वाढवायचे किंवा ते जपून कसे ठेवायचे हे माहित नसतं. आणि बऱ्याच वेळेला आपणाला काही फायनान्शियल एड्स लोक द्यायचा विचार करतात आणि आपण न्यूजपेपर मध्ये बऱ्याचशा बातम्या ऐकतो की ह्या डॉक्टरला लुटलं, त्या डॉक्टरला लुटलं, म्युच्युअल फंड्स मध्ये पैसे कलेक्ट केले, फॉरेक्स मध्ये पैसे कलेक्ट केले आणि बऱ्याच वेळेला आपण लुटलो जातो. मला असं वाटतं की आपल्या मेडिकल करिक्युलम बद्दल हा सुद्धा एक महत्वाचा करिक्युलम आहे आणि तो आपल्याला यायला पाहिजे. थोडक्यात सांगायचं तर आपली अशी अवस्था असते की आंधळं दळतं आणि कुत्रं पीठ खातं. की बऱ्याच वेळेला आपण जे काही कमवलेलं असतंय तेच आपल्या म्हणजे आपणाला टिकवून ठेवायचं माहित नसते किंवा ते वाढवायचं माहित नसते. आपण फक्त ते कमवत राहतो आणि कमवत राहतो. पण कमवण्यापेक्षा जे आहेत 2 पैसे ते वाढवणं पण तितकंच महत्वाचं आहे. आणि अशा कॉन्फरन्स मधनं किंवा अशा सेमिनार्स मधनं नक्कीच डॉक्टरांना कसे पैसे वाढवावे हे कळेल आणि त्या नॉलेजची खरंच गरज आहे असं मला आज वाटतंय. एवढं थोडंसं मला हे जे काय भावलं आत्ताच्या ह्या सेमिनारमध्ये ते मला सांगावं वाटलं आणि मला आनंद झाला की मी 2 तास बसून इथे हे सगळं फायनान्शियल आस्पेक्ट्स ऐकले. त्याबद्दल मी सातारा IIM आभारी आहे. आणि असेच पुढच्या कॉन्फरन्समध्ये सुद्धा डॉक्टरसाठी प्रोग्राम ठेवा की ज्यामुळं की फायनान्सेस बद्दल लोकांना एक बेसिक नॉलेज मिळेल. कारण मी आत्ताच सांगितलं तुम्हाला की स्टॉक मार्केट बद्दल मला काहीच माहित नव्हतं इनफॅक्ट. आणि लॉकडाऊनमध्ये काही काम नव्हतं म्हणून मी सहज असं स्टॉक मार्केटचे काही व्हिडिओ बघितले आणि मला जरा थोडंसं त्यातनं एक नॉलेज थोडंसं आलं आणि त्याच्यानंतर मी ठरवलं की आपण इन्व्हेस्ट करून बघूया. माझा काय पोर्टफोलिओ फार मोठा नव्हता. पण मी इन्व्हेस्ट केले, थोडेसे पैसे मिळाले, विकून टाकला आणि रिकामा झालो. त्यानंतर मी अजूनपर्यंत काही चार्ट्स बघितलेले नाही आहेत. मला असं वाटतं की मला पण आता चार्ट्स बघायची इच्छा होईल इथून परत गेल्यानंतर. थँक यू व्हेरी मच आणि थँक यू मला थोडासा टाइम दिला बोलण्यासाठी. थँक यू व्हेरी मच. ओके.
मी डॉक्टर सूर्यकुमार खंदारे सरांना सांगेल की आजचे MMC ऑब्झर्वर संजय पवार सर फ्रॉम कराड फिजिशियन त्यांना शाल, श्रीफळ आणि मोमेंट देऊन सत्कार करावा.
Workshop, we have taken a good message. Don't run behind product of prestige. Yes, na madam? We should know how to multiply our income, which we have generated with our lot of efforts. So this workshop really will help all doctor fraternity to increase their wealth by investing in a right manner, that is GERD, what Sudhir sir has rightly explained. Thank you for participating in this today's workshop.
मी डॉक्टर शरद जगताप सरांना विनंती करतो की त्यांनी आत्ताच्या वर्कशॉपचे फॅकल्टी यांचे पुष्पगुच्छ आणि मोमेंट देऊन सत्कार करावा. डॉक्टर सुधीर कदम, डॉक्टर शिवाजी सोनवणे, डॉक्टर दीपक बनकर, डॉक्टर निलेश भुते. प्लीज कम ऑन स्टेज. I request Dr. Jyoti Madam to come on stage and felicitate Dr. Aparna Jagtap Madam.
Lot of thanks to all of you who are attending this workshop. I declare that today's session is concluded. I very much thankful for the audiovisual team, my colleague Kiran and Shivaji Sonavane for conducting the today's workshop. And I declare that today's session is concluded. Thank you.